Good afternoon, friends. I'm Dr. Puneet Jain. I'm your host for the day. I would like to begin by extending warm welcome to all our wonderful delegates, my dear colleagues, and our patrons of the day. Our regional CEO, sir, Mr. Santosh Marathe, sir. Our Director of Oncology, Dr. D. Cruz, is not here. Our unit head, Dr. Kiran Shingote, our DMS, Dr. Ravi Shankar, and all my oncology colleagues and my senior physician friends at Apollo. Welcome. So there is a saying, capture the crowd's initial attention and then you don't have to worry about their span. And hematology is one such subject. From simple cases to complex, unfathomable conclusions, it can drive your interest and at the same time drive you nuts in coming to a conclusion. Today's hematology meet, that is Anemia Masterclass, is such an event, and I welcome one and all for today's meet. We have a very distinguished list of virtual and we have speakers here too, chairpersons and panelists to enrich your day. Questions are welcome, but in the designated time zone or the last 5 minutes of every session. Now, if you look at statistics, 50 to 60% of reproductive age women, adolescent, children, and a lot of men are actually anemic. Now, there are problems like fatigue, poor concentration, exertional breathlessness, palpitations are all probably related to anemia, and we end up actually missing it in our diagnosis. Now, in line with the government initiative of Anemia Mukt Bharat, we are launching anemia clinics today. I now invite Marathe sir and entire leadership, my fellow physician colleagues, for the inauguration program, and then we start our program. Please come onto the stage for the inauguration.
जे आहे ना इथे डुप्लिकेट करता नाही तर फुल स्क्रीन जाणार नाही तर डिस्प्ले तिकडे आउट होतोय इथे करायला पाहिजे नाही होत रिव्ह्यू जाते डुप्लिकेट कंट्रोल शेअर नाही शेअर केलं ते आता तुम्ही शेअर करा इकडून करून ठेवा ना पाहिजे का आपलं पहिलं आहे ना
So, with this, Thank you, everyone. We now start with our academic program. For the first session, I'm going to invite my senior physician colleague, Dr. Bharat Agarwal. No, he doesn't need an introduction. He's a very popular physician at Apollo. Dr. Bharat, please come onto the stage. I invite Dr. Suvadeep Sen. He's our intensivist at Apollo. He's handled quite a lot of complex cases, including complex anemias. I hand over the dais to Dr. Bharat and Dr. Suvadeep for the first session by Dr. Aditi Shah. Is she online? Aditi, you're there? Aditi, switch on your camera.
Yes, I am online.
Yeah, hi. Okay.
Hi, sir.
Good afternoon, everyone. We'd like to welcome Dr. Aditi Shah. She is talking on hemolytic anemia, a practical approach. She is a hematologist who's finished her MBBS from Sion, post-graduation in medicine from Pune, and a clinical hematology from Bangalore. Currently, she was working with Hemat department at KEM Hospital and has multiple presentations. Currently, she is a consultant hematologist at Parak Hospital. And over to you, Dr. Aditi Shah, for the talk.
Thank you, Chairperson, for the kind introduction. And I would also like to thank Dr. Puneet Jain for the invite. I will just share my screen.
If you can hear me, please put
Yes,
it on full
yes,
screen.
I'll put it on the slideshow. I'll put my video off because of some network issues, if there are any, while presenting. Thank you, everyone. So I will start my lecture. My topic is hemolytic anemia, a practical approach. So as we all know, anemia has broadly three categories: blood loss, hyperproliferative, and hemolytic. Hemolytic anemia by itself is a wide spectrum of disease which has congenital and acquired causes. From the point of view of pathophysiology, it has been divided into intravascular vascular hemolysis and extravascular hemolysis, but there is always an overlap in a lot of these etiologies. Clinical manifestation and management of these cases are cause specific. So this is a very basic classification of causes of hemolytic anemia, which is divided into acquired and congenital and intravascular and extravascular hemolysis. So in detail, the congenital causes are mainly hemoglobinopathies, commonly the beta thalassemia trait usually do not present with hemolytic anemia, it is incidentally detected. Thal intermedia and Thal major are the ones which cause a problem. In that, they are either transfusion dependent or non-transfusion dependent. What we see in adult practice, if it can cause a diagnostic problem, is the non-transfusion dependent anemias, because the transfusion dependent ones are usually diagnosed at 6 months to 1 year of age. Alpha thalassemias, rare, but it can still present with hemolytic anemia, HBH disease to say. Sickle cell disease, again, it can be homozygous sickle cell disease, or there can be a co-dominant mutation, HBS beta, HBSC. S beta and homozygous sickle cell are common. There are other rare hemoglobinopathies like HBE, HBE beta, HB lipo, which rarely some cases may have. Next is enzymopathies, commonly G6PD deficiency and pyruvate kinase deficiency. There are many other rare enzyme deficiencies which we don't need to get into. So G6PD deficiency, again, these cases usually have episodic hemolysis at the time of if there is an exposure to a trigger like infection or drugs. And pyruvate kinase deficiency patients usually have a chronic hemolysis ongoing, which so they will have a chronic fatigue or chronic jaundice. Next is membrane disorders. Common one is hereditary spherocytosis. Again, these patients have a varied presentation from asymptomatic to severely symptomatic. The asymptomatic ones may be incidentally diagnosed in adolescent or adulthood because of presence of splenomegaly or mild anemia when they are getting operated, or there is some other medical incidental medical in examination. Rest hereditary erythrocytosis, tomatocytosis, poikilocytosis, etc., but they are again rare. And the last congenital form is atypical hemolytic uremic syndrome. Again, this is due to some complement pathway defect, which is a rare phenomenon. Here we come to acquired causes. So in adult, when a patient is diagnosed with hemolytic anemia, more often will have an acquired cause. Commonly is autoimmune hemolytic anemia. Next common is thrombotic microangiopathy. Occasional patients may have paroxysmal nocturnal hemoglobinuria. A lot of patients with infection may also develop hemolysis, and very rarely mechanical hemolysis, which is usually in theory seen in marchers or people who use heavy drums. But again, in practice, the hemolysis is very mild, so we don't see such patients. So talking in detail, a little bit detail about autoimmune hemolytic anemia. So it occurs due to presence of autoantibodies against various RBC antigen, commonly Rh group antigen, I antigen, P antigen. Most of these cases, 70 to 80%, are because of warm autoimmune antibodies. So what are these warm antibodies? Basically, they are polyclonal immunoglobulin G type of antibody, which attach to the RBC at 37 degrees Celsius temperature. And these RBCs are opsonized by the antibody, but they are usually phagocytosed by the macrophages in the spleen, sort of an extravascular hemolysis, mainly occurring in the spleen. On the contrary, cold autoimmune hemolytic anemia usually occurs because of monoclonal IgM type of antibody. These antibodies attach to the RBC at low temperature but cause hemolysis when the temperature crosses 22 degrees Celsius. And these are mainly phagocytosed by the macrophages in the liver. So this is important because the treatment of the two differ because of this pathophysiology. So again, autoimmune antibody etiology-wise, warm, which is the common. Primary, that is idiopathic, will be about 50% of the cases. And almost 50% or more cases will have some secondary cause, which can be either autoimmune disorder, underlying malignancy, infection, drugs, or occasional patient with primary immunodeficiency disorders. So what to remember about these patients is always during taking history and while doing investigation, one should always look for a secondary cause, which I will talk in little detail about further. One point about primary immunodeficiency disorder, which people usually forget, is if a child or an adolescent or even occasionally adult having multiple episodes of autoimmune hemolytic anemia, along with other autoimmune thrombocytopenia, neutropenia, and also having recurrent infections. So one should always send a immunodeficiency panel. Cold autoimmune hemolytic anemia may be primary or secondary. Most often they are secondary, so we thoroughly always look for an underlying cause. Secondary infection, mycoplasma, common, which we all know, some other respiratory tract infections. And malignancy, most commonly is IgM, MGUS, or lymphoplasmacytic lymphoma. Occasionally AITL, some solid tumors. Next comes thrombotic microangiopathy. So TMA is actually a general term. It is an umbrella for many other etiology lying under it. So microangiopathy, the word itself means that there is RBC fragmentation occurring in the circulation, usually the smaller blood vessels. So in this, the two most common causes are TTP and HUS. So TTP per se is TMA without an obvious profounding factor and usually without an oliguric renal failure. And it occurs due to presence of autoantibodies against ADAMTS13. There is a rare form of congenital TTP, which is because of the deficiency of this protein ADAMTS13. It is also known as Upshaw-Schulman syndrome. Hemolytic uremic syndrome, on the other side, occurs because of oliguric or anuric renal failure. So the distinguishing character between these two is presence of renal failure. Of course, there may be some overlap. And again, HUS, there are two types. Common one is the acquired HUS, that is following a STEC, Shiga toxin E. coli infection. So there may be an antecedent history of a diarrhea or a dysentery. Occasional rare forms, atypical HUS, which I said was a congenital form. So apart from TTP and HUS, the other secondary TMAs may be because of infection, maybe because of a pregnancy, which is commonly seen in our practice, patients with preeclampsia, eclampsia, or HELP syndrome. In tissue transplant associated, that is, it can be maybe following a hematopoietic stem cell transplant or a solid transplant. So in our setup, following hematopoietic stem cell transplant, it is actually a common trouble. Can be because of tissue injury, because of chemotherapy, radiation therapy, or rejection, or GVHD, and also drugs, mainly cyclosporin or tacrolimus associated. Other secondary causes are malignancy, autoimmunity, drugs, malignant hypertension, and one more common factor which we see in our practice is a prosthetic heart valve which is not functioning. In this category, also some grafts or stents can rarely cause TMA. Next is paroxysmal nocturnal hemoglobin So this is an acquired clonal disorder. So there is a single gene mutation in the PGA gene, which produces the GPI anchored proteins. PGA gene mutation leads to deficiency of the GPI anchored proteins on multiple cells, but for our important on RBC, it especially leads to loss of CD55 and 59, which these proteins are protective for destruction against the complements. So loss of these protein leads to complement mediated hemolysis. So classical PNH is the one which has hemolysis and increased risk of thrombosis. And there can be some PNH clone in association with aplastic anemia patients. So infection per se has multimodality to cause hemolysis, which we already saw, autoimmune thrombotic microangiopathy. There can be direct destruction of the RBCs, like in case of malaria. And there can be even hypersplenism itself can lead to hemolysis to again malaria, schistosomiasis. So this is multimodality of hemolysis in various infections. So practical approach to a hemolytic anemia patient. So there are two questions to be answered. One is it a hemolytic anemia? Second, if yes, what is the etiology? And once we find the etiology, only then we can give specific treatment for the etiology. So to answer the first question, a detailed history physical examination is required. So in history, the onset of symptoms, if it is a chronic symptom, if the symptoms are since childhood, or if it is a subacute to acute onset of symptom, which can differentiate between the congenital and acquired cause. Of course, in few cases, there is always an overlap between the two causes. Symptoms of anemia, usually all of them will have fatigue, exertional dyspnea, dizziness, tinnitus. Jaundice may or may not be present. Essentially, jaundice is present in congenital causes like thalassemia, sickle cell anemia, or some where enzyme deficiency like pyruvate kinase deficiency, where some chronic hemolysis is ongoing. Even in acute cases, if there is a severe hemolysis, they will have jaundice. cola-colored urine is actually seen in very few cases. Even in PNH, not all patients present with cola-colored urine. It is a misnomer. And otherwise, it can be seen in severe AIHA or in alloimmune hemolytic anemia. Splenomegaly again won't be present in all cases, but if present, it is present in few hemoglobinopathies like sickle beta thal or thalassemia or hereditary spherocytosis. Acquired cases usually won't have splenomegaly. Episodic painful crisis in sickle cell disease. Leg ulcers again commonly seen in hemoglobinopathies. Other questions like fever, joint pain, rash, alopecia, loss of weight, loss of appetite, all this is to look for any secondary cause causing hemolysis. Drug history and family history is also important. So based on history, physical examination cues to differentiate between a congenital and an acquired cause. So usually a congenital cause, their patient will be symptomatic for a long time, probably since childhood. Jaundice may be present, splenomegaly will be present. Because of chronic hemolysis going on for a long time, these patients usually have gallstones. Leg ulcers may be present in few cases. Symptoms specific for each disorder, for example, recurrent pain crisis in sickle cell disease, or some extramedullary masses, extramedullary hematopoietic masses in NTDT. Usually these symptoms will worsen if there is a acute trigger like an infection or a trauma or surgery or some drug exposure. And family history, so few of these patients may have a positive family history, especially in sickle cell disease. Since it's transmitted autosomal dominantly, there is always a presence of family history. And history of blood transfusion, a lot of the congenital anemia require recurrent blood transfusion. On the contrary, acquired cases, the onset of symptoms is fairly subacute to acute. Jaundice, splenomegaly, usually not present. Jaundice may be present in severe cases. Symptoms for underlying disorder, as we saw, acquired causes, a lot of them have a secondary underlying etiology, so symptomatic for them. And they may have similar episode in the past, like an AIHA may relapse multiple times. Even TTP may have a history of previous episode of TTP. Example, a TTP during first pregnancy and then during a second pregnancy and so forth. So based on history examination, based on these symptoms, we go on to CBC. In CBC, hemoglobin will be low, obviously. In congenital anemia, MCV is usually low in thalassemia or normal in sickle cell disease, hereditary spherocytosis, enzymopathies. But it is usually high in acquired causes, which is mainly because of reticulocytosis. A typical finding in hereditary spherocytosis is high MCHC. RDW may be normal to wide. Reticulocyte count is very important, plays an important role. So as we know that it has retic count is either automated or manual. So manually we count per field number of reticulocyte divided by the number of RBCs. But only retic percent, it does not give a clear picture. So we usually take a corrected retic count, which is corrected for hematocrit or hemoglobin of that person. So from the corrected retic count, occasionally we can also do reticulocyte production index, but CRC is also good enough to give a good picture if retic is elevated or no. And absolute retic count can be detected from the total RBC count. So usually reticulocyte cytosis is said when CRC is more than 2% or absolute retic count is more than 1 lakh. And there is reticulocytosis in most of the cases of hemolytic anemia. But again, some cases, the reticulocyte count may be normal or even low, but it does not exclude hemolytic anemia. So these are the patients, especially in AIHA, if there are autoantibodies against RBC precursors as well, may have a low retic count, or if there is a parvovirus infection, or if there is aplastic crisis, especially in the hemoglobinopathies due to folate or B12 deficiency. In such cases, retic will be low. In other investigations, LFT will show indirect hypobilirubinemia, LDH will be elevated, haptoglobin will be decreased. So this entire picture will give us a confirmation that what we are dealing with is a hemolytic anemia. Now what we need to know is what is the etiology of hemolytic anemia. So next very important examination is to examine the peripheral smear. It is very vital in making the diagnosis. So it will have some general picture for all hemolytic anemia, which is mainly polychromasia, that is because of the reticulocytosis. And some patients even may have NRBCs. And then there will be findings which is specific for each disorder. So here we'll go through few peripheral smear of each disorder. So this is a case of severe beta thalassemia, that is either major or intermediate, we can say. Microhypo target cells, polychromasia, NRBCs. So in a beta thal major, usually there will be NRBCs, and the microhypo won't be uniform like how we see in a thal trait. There will be a lot of little bit of anisopoikilocytosis and a bizarre blood picture. That's what it is called. So this is how we can take the next decision to do the next step to do a confirmation, that is HPLC. Here we see a peripheral smear of sickle cell disease. Again, polychromasia is present. These are the sickle cells. They can be of various shapes. It can be leaf shape, boat shape, cigar shape. Usually once the cells have formed a sickle shape, they are called irreversibly sickle cells. Usually sickle cell homozygous have splenic hypofunction, so even basophilic stippling can be seen, which is what we see here. Hereditary spherocytosis, these cells, there is loss of central pallor. So these dense looking circular cells are spherocytes. AIHA, again, reticulocytosis, NRBCs, along with that they have microspherocytes. This is because of phagocytosis of not complete but partial phagocytosis in the spleen, and then loss of the surface, and then they form microspherocytes, so which is a common finding in the AIHA smear. Autoagglutination in warm AIHA may or may not be present, but in cold AIHA autoagglutination, large clumps can be seen. And thrombotic microangiopathy. So this actually, this was looking at a smear for TTP and HUS, and immediately acting on it is very vital to save the patient, because these patients are usually sick. So one should always know how to diagnose schistocytes. Usually they have pointy edges, loss of central pallor. They can be helmet cells or they can be of various shapes. So, and the number of schistocytes counted based on the number of schistocytes divided by the RBC. So more than 1% is significant in such cases. So once we see the peripheral smear, it gives us a picture on what should be the next test to be done to confirm the diagnosis. So if we are suspecting hemoglobinopathy, HB electrophoresis or HPLC is done. Here basically because there is in HPLC there is a cationic exchange method where the hemoglobin have different ionic strength, and then they get eluded at different retention times. So based on the retention time, they form a peak in the graph. So HbF is the first one, followed by HbA, then HbA2. HbA2 window, a lot of other HbE, LEPOR also fall, but for our for this lecture, we will concentrate on HbA2, then HbS. So depending on the peak and the area under the curve, the percentage of that hemoglobin in the blood can be estimated. So normal HPLC, this is how the graph looks like, and the values are something like HbA will be about 95% or more, HbA2 will be 2 to 3.5%, and HbF usually less than 1%, a little bit above 1% is also okay. So thal trait is very commonly seen in our practice. Usually this patient, as I said, are asymptomatic nothing to be done, but prenatal counseling is what is important. So here the diagnosis is made based on the presence of elevated HbA2. The range is 3.5 to 7. Some lab take this range as 4 to 7. Beta thal major, usually here because the beta globin gene is not there, your HbA will be very low. In compensation, HbF is very high, it may be more than 90% also. HbA2 may be normal or elevated. There are some cases where HbA2 will be low. So if the patient is clinically presenting as thal major, then it can be delta beta thal. However, if the patient is clinically normal and there is just elevation of HbF with normal HbA2 or low HbA2, there is a condition known as hereditary persistent of fetal hemoglobin. That is what the diagnosis will be. Then sickle cell trait, here hemoglobin S value is usually up to 30 to 40%. This is the spike of HbS, but HbF will be normal.
Dr. Aditi, just 2 minutes left for your slides.
Oh,
If you
okay.
can make it a little faster.
Okay. So I'll just quickly brush through HbS, homozygous, HbF and S both will be elevated. We'll skip this for hereditary spherocytosis. EMA testing is done. Coombs test again for AIHA. So Coombs DCT is important. ICT usually is not required. And PNH flow cytometry. Again, management is case specific. So I have put forth few cases. I'll just quickly go through them. A 23-year-old male presenting from Nasik came to the OPD with a history of intermittent painful episodes since childhood and one episode of pneumonia in the past, and that time required oxygen support. So he was referred by a general physician who thought that there is something more to this patient to be done. There was family history of similar complaints in younger sister who was also not evaluated. There was pallor on general examination. Investigation showed HB of 8.4. Rest of the parameters were normal. Retic was 10%, and this was the smear findings where we see the sickle-shaped cells. So to confirm, HB electrophoresis was done where HBS was 74% and F was 14%. And the diagnosis of sickle cell anemia was made. So why I put this case forward is that even in an adult patient, sickle cell can be diagnosed for the first time. So taking history is quite important, and again going to the smear and further investigation. So he was started on hydroxyurea and regular follow-up was done. Case 2 is a 34-year-old female who presented with a progressively worsening dyspnea since last 2 days. Otherwise, the past history, family history is not significant. Examination showed pallor and icterus. Investigation, HB was 4.2, MCV was 104. Retic was elevated, LDH elevated, creat slightly elevated, haptoglobin low. So this is the smear where we see some autoagglutination and we see polychromasia. So DCT was done, which was strongly positive for IgG and C3d, which confirmed the diagnosis of warm AIHA. This patient was treated with methylprednisolone. She had a good response to steroids, so it was continued and gradually tapered over next 10 months. She stayed in remission for 2 years and relapsed after 2 years with similar complaints, but also had symptoms and later found to have pulmonary TB. So at relapse, because of presence of TB, steroids could not be given for a higher dose and longer duration. Rituximab could not be given. So simultaneously, MMF was started. Steroid was tapered a little quickly in this time, over 6 months. And the lowest possible dose was tapered to very quickly. MMF was continued, and now it is 18 months from the first relapse. She is on MMF and hemoglobin is normal. Case 3, 26-year-old female, 34 weeks of gestation, no previous significant history, presented with history of dizziness, headache, and breathlessness. So she had pallor on examination, tachycardia, otherwise rest was normal. HbU 6.6, MCV elevated, platelet 40,000. On smear platelet for her were even less, about 20,000. Creat was normal. There was indirect hyperbilirubinemia, but enzymes were fairly okay. LDH was elevated to 1200, TCT negative. So this is the smear. So the smear shows presence of schistocytes. And because also coagulation parameters were normal, so the diagnosis of TTP was made. ADAM-TS13 levels were sent, but usually the report takes a while to come. We cannot wait for it. The fetal viability ultrasound was done. Fetus was okay. Diagnosis of TTP was made. This patient was started on plasma exchange and prednisolone. After 6 sessions, her platelet improved to more than 1.5 lakhs. So Plex was stopped, prednisolone was continued. There was a multidisciplinary approach to this patient, keeping the obstetricians and the ICU physicians in the loop. So after her platelet recovered, after 2 weeks of hospital admission at 36 weeks of gestation, she was delivered with a healthy baby. So I end my lecture here. So I presented some common cases which we see in our routine practice. This topic is very vast and very in-depth presentation could not be done, but I thank you for your patient listening.
Thank you, Dr. Aditi, for a very nice and lucid presentation, and very nice to have 3 cases which emphasize the various cases of hemolytic anemia. Now, any questions from the audience if anybody wants to ask?
Thank you, Aditi. Wonderful talk. And I just had one question for you, and probably of importance for our audience. If many times patients with hemolytic anemia, they come in a situation where the hemoglobin is very low, right? So the first reaction is not to actually evaluate the hemolytic cause. First reaction is to give blood. Would you agree with that?
I agree with
Right.
you,
So now my question for you, my question for you is, what do you think are the tests that we should avoid? We should avoid as part of hemolytic anemia. As once a patient has received blood, what do you think we should avoid doing the test? What test do you think we should not do it on an immediate basis?
Yes, sir. So on an immediate basis, test which after blood transfusion, test which cannot be done, like won't be of any use, will be HB electrophoresis or HPLC, and it is not necessary also to act, that is to manage the patient on emergency. Subsequently, PNH cannot be done to up to 7 days from giving blood transfusion. After that, we can send it. ADAM-TS13, again, TTP is a very emergent condition. If we are able to send it, we send it. If not, we just treat the patient based on clinical judgment and smear report. So,
what about enzyme levels? That also we tend to avoid,
enzyme
right?
levels we don't send at the time of an acute episode. Yes, sir.
I think, thank you. Thank you for the great talk, Aditi. Thank you for joining us.
Thank you so much, sir.
Yeah. I now request Mansi to felicitate our chairpersons. And thank you, Aditi. If you were here, we would have loved to felicitate you maybe next time.
Thank you, sir. It was a pleasure to attend and
Thank
present.
you. Thank you. Thank you, chairpersons. Yeah, Subhadeep. Thank you, Dr. Subhadeep and Dr. Bharat, for chairing this session. We now move on to our next session on iron deficiency by Dr. Nilesh Vasekar. For that, I would like to invite again two senior physicians, Dr. Vaishali Lokhande. She's also our DNB teacher, and Dr. Divya, she's our intensivist on the stage. Thank you. Nilesh, are you online?
Yes, sir.
Yes. Yeah, great. So, the intro, CV. Nilesh, you have 20 minutes, please.
Okay.
Thank you.
Can we have the CV displayed?
Yes, that's it. ये चालू है?
Yeah, for the next talk of the day, we have Dr. Nilesh Vasekar, who is a MD Medicine and a DM Hematology. He's a fellow in BMT, consultant hematologist at Nashik Hematology Services. Over to Dr. Vasekar for talk on iron deficiency anemia, all about it.
Thank you, ma'am. Can you see my screen?
You have to share
No,
the
not yet.
slides.
You will have to share the PPT. You should we share it from here, or you will be sharing it?
Yeah. Is it visible now, sir?
So you will have to share the. Can you share it from your side, Nilesh?
Yeah.
Yeah, you share it from your side. Otherwise, yeah, great. We can see it.
Okay, okay. So, first and foremost, I would like to thank Dr. Puneet Jain sir for giving me this opportunity. Puneet sir is my teacher, and I have learned a lot of hematology from him. And we were together at Global Hospital. So, and thank you for giving me such simple topic of iron deficiency anemia. Though iron deficiency anemia, we think it is simple, but it can be a complicated one whenever we get some tricky cases. So, in iron deficiency anemia, I'll be talking about what is iron deficiency and how to treat it, and we'll look after some of the interesting cases which came across during my tenure of last 10 years in hematology, and we'll try to give some gist about the management of iron deficiency. So iron deficiency anemia, the definition is clear. You need to have low hemoglobin and a patient who has some issues with some sort of bleeding or diet intake is improper, and his MCV, his or her MCV is less than 80, and if you have low ferritin, and if your hemoglobin is less than 12 or less than 12 in women and less than 13 in men, then iron deficiency anemia is clear cut. And such cases, we do see it on regular basis in our OPD. Most of the my physician colleagues do see these cases on regular basis. So coming to first case, a 54-year-old lady, she has she has presented with generalized weakness, and she was referred in view of anemia and easy fatigability. Her CBC, you can see the CBC on screen. Hemoglobin is 8.2, MCV is 69.4, and RDW, if you can see, RDW is high, it is 70. So these three parameters, while checking patients, anemic patients, whenever we are seeing those patients, we should look at those parameters. One is RBC count, second is MCV, and third is RDW. Most of the possible diagnosis you can clearly get it from these CBC reports. And as MCV is low and RDW is high, mostly we are dealing with iron deficiency anemia or a dimorphic anemia. So her further workup was done in the form of, while reading the CBC, we should look at RDW. If your RDW is normal and MCV is low, we can think about anemia of chronic disease or beta thalassemia trait. If your RDW is high and MCV is low, then iron deficiency anemia is higher on cards. Other diseases like sideroblastic anemia can be there. If your MCV is normal and RDW is high, combined or mixed deficiencies higher on cards, anemia of chronic disorder can be there. And if your RDW is high and MCV is also high, you should think of megaloblastic anemia. So her iron studies were done, which was showing a picture of iron deficiency anemia, clear-cut iron deficiency anemia, and this was a peripheral smear, which shows hypo, micro, as well as pencil cells, and microcytosis is quite evident from the peripheral smear. So peripheral smear is also important because most of the time we do get a picture of iron deficiency, as well as sometimes you can get basophilic stippling on peripheral smear, which suggest the presence of late toxicity or sometimes very severe vitamin B12 deficiency also. Peripheral smears can help in diagnosing dimorphic anemias, like if some patient is having iron as well as B12 deficiency, you will get the picture of dimorphic anemia also. Sometimes PNH can be picked up on peripheral smear where you have iron deficiency along with hemolysis, picture of hemolysis, polychromasia. Then we can think of paroxysmal nocturnal hemoglobinuria also. So for this patient, iron studies were clear-cut suggestive of iron deficiency anemia, and the diagnosis was clear. But she was treated with IV iron, but her easy fatigability and other symptoms were persistent. So we thought we'll go back and see what is the basic cause behind that anemia or iron deficiency anemia. While evaluating, before evaluation of these patients, sometimes you get these patients on whenever you get these patients in emergency, and these patients need a transfusion on emergency basis. So we can keep the sample for evaluating iron studies. But sometimes if you do not have a sample, what can you do? After one transfusion, you can check ferritin. After one transfusion, if you are suspecting hemolytic anemia, you can do haptoglobin and LDH. After two transfusions also you can do it, and it is it can be still low in hemolytic anemia despite of giving transfusion. B12 deficiency also you can do B12 level after transfusion, but folate level you cannot do because folate level will come high after one transfusion. And iron studies definitely you cannot do after PCV transfusion, only ferritin you can do. So for that patient, we thought we'll do further workup, and her further workup was done. Stool for local blood was positive, and OGD scopy was done. OGD scopy was suggestive of mass in GE junction. So she was referred to medical oncology colleague, and further treatment was done at his place. So this is how iron deficiency anemia we should diagnose iron deficiency anemia, and a basic cause behind that iron deficiency anemia should be sought for, and depending on that, we can treat it. Like majority of iron deficiency anemia in our clinical practice is diet related, as we all know, and and if you see iron deficiency anemia, what are the stages? In iron deficiency anemia, we have iron deficiency without anemia. In that case, you will have only low ferritin, and other parameters will be normal. If you are doing a bone marrow in this situation, your iron will be absent. While if you see iron deficiency anemia with mild anemia, in that case you will have less iron and low level of ferritin also. But in full-fledged anemia, in full-fledged iron deficiency anemia, all the parameters will be on lower side. So similarly, we can get similar cases in OPD where you get the patient who is saying that you have hemoglobin always in the range of 9 to 10. So what to do? So this is another case where a 57-year-old lady, she had came to me with generalized weakness, and she was already worked up at a physician level, where our CBC was done, iron studies, ferritin, B12, everything was normal, but hemoglobin was always in the range of 9 to 10. This is our CBC. You can see hemoglobin is less, and MCB is also on lower side, but if you can see, RDW is in the normal range, and RBC count is not that low as compared to the hemoglobin. So there is some there is this hemoglobin and erythrocyte count is disproportionate. So in this situation, and iron studies and everything was normal. So it is advisable to do thalassemia workup in this situation, and her HB electrophoresis was suggestive of thalassemia trait. So similar cases you can get in your practice, where you can get iron deficiency anemia, and thalassemia trait is also very common in our area. So Menzel's index, we can take help of Menzel's index while suspecting such cases. When you see CBC report, you can calculate the Menzel's index with the help of MCV and RBC count. If it is less than 13, thalassemia trait is a possibility. If it is more than 13, iron deficiency anemia is more likely. But sometimes you can get some patients where you have anemia, iron deficiency anemia, B12 deficiency anemia, and thalassemia trait. All three are together, and then Menzel's index will not work. So coming to the aim of treatment in iron deficiency anemia, as I already mentioned, we should treat the iron deficiency anemia and we should search for the cause of iron deficiency anemia. Whatever is the cause, we should look at it and we should treat it. So as iron deficiency anemia is diet related, most of our patients, like I would say 70 to 75% of cases will have diet related iron deficiency anemia. So for those patients, we should give iron supplementation, but diet modification is very important. And in diet modification, we should look at what is the required daily allowance of iron on daily basis. If you see, in adult, it is 8 to 12 milligram of iron per day is required, and depending on the content of iron in various food products, we can give them a diet chart, and we should try to increase the intake of iron to treat that iron deficiency. Along with iron supplement, this diet should be given, diet chart and diet modification should be done, because that patient can come after 3 to 4 years with the similar complaint. So we should look at the cause and we should treat that. So how to treat iron deficiency anemia? We should calculate the deficit. The simple formula is if you have weight above 50, 1500 milligram iron can be given. If weight is less than 50, 1000 milligram can be given. In oral, the dose is 6 milligram per kg per day. Ganzoni formula, we all know. With the help of Ganzoni formula, we can calculate the deficit, and we can see, we can calculate deficit along, and we can add 500 milligram additional to replenish the stores. So in a day, how much iron is required? Single tablet is sufficient. If you are giving 375 milligram of ferrous sulfate, 65 milligram of elemental iron will be there, and only 25 milligram is absorbed in a day. So even if you are giving 2 or 3 tablets, only in a day, your body will absorb 25 milligrams. So single tablet is sufficient. Alternate day iron, there are some patients who do complain about constipation and abdominal pain because of iron preparations. So for those patients, we can have an option of alternate day oral iron, which has been proved 5 to 6 years ago that alternate day iron is also equally efficacious as compared to the daily iron. It has some hepcidin-based mechanism. Hepcidin will prevent the absorption of iron. Even if you are giving on alternate day basis, same amount of iron is going to get absorbed in your body. So alternate day iron is also possible and can be done. What are the common brands? We generally write Vitcofol, and what is the content of Vitcofol? So if you see, it is ferrous fumarate, and in Orofer XT we have ferrous ascorbate, and in Fifol there is ferrous sulfate. All the products, whatever common products are available, they are equally efficacious. They try to say it is one product is not efficacious or is not that tolerable over other. So most of the products are similar. They have similar side effects. They have similar efficacy. So how much duration of oral iron should be given? For recovery of anemia, you'll need 4 to 8 weeks of iron. And for recovery of the stores, the iron supplementation should be continued for 3 to 6 months. What about vitamin C? Most of the patients, most of the physicians advise vitamin C with iron. Even if you give vitamin C with iron, or even if you are not giving vitamin C, there is no difference. It has been proven in RCT. There are new molecules coming in the market, like heme iron, iron pyrophosphate, liposomal iron. Heme iron is supposed to be absorbed as better as compared to non-heme iron, but there are no RCTs to suggest heme iron or iron pyrophosphate or liposomal iron is superior over the traditional iron preparations. There can be some form of decreased GI trouble with these products, but still we do not have major data from RCT. To check the response of oral iron, we need to do hemoglobin on day 14. If hemoglobin is increasing by 1 gram on day 14, you should continue the oral supplement. But if it is not, then parenteral option can be discussed. Reticulocytosis will get after 72 hours of start of the therapy, and hemoglobin should increase by 1 to 2 gram every 2 weeks on every 2 weeks basis. If it is like that, you can continue the oral supplement only. For those with suboptimal response to oral iron, what can we do? We can switch to alternate day. We can give iron tablets before food, avoid calcium, tea, coffee, eggs, can shift to syrup, and avoid antacids, PPI along with the iron. Coming to IV iron, we have dextron is out of use, but iron sucrose is still there. Iron sucrose can be given as a total infusion. You should not increase doses above 300 milligram. And recommended dose for infusion is 200 milligram injected over 60 minutes, can be repeated every 2 to 3 weeks basis in patients of cancer and anemia. Maximum dose per week is 600 milligram, and you can get some sort of side effects with iron sucrose like hypertension, tachycardia, and dyspnea. Test dose is not recommended. What about FCM and isomaltose? Both are equally efficacious. FCM has some issue with hypophosphatemia, while isomaltose does not. Both are equally efficacious, and the propensity of development of hypersensitivity reaction is equal in these two products.
Dr. Nilesh, sorry to interrupt, just 5 minutes more.
Yeah, okay. So what about hypersensitivity reaction to iron? If you see this chart, iron dextran had 9.8% of hypersensitivity reaction, while sucrose 1.2, and FCM, you can see it is 0.8. So the difference between iron sucrose and ferrous carboxymaltose is 0.4. So I think both are FCM is better than iron sucrose. But if some patient is non-affording, then iron sucrose is still good. Whereas the other product, ferumoxytol, has more chances of side effects. So you need to be careful while using ferumoxytol. There is something called Fishbane reaction you can get on OPD in your IPD setup. Whenever you are starting the patient on IV iron, it is common, and you will get it in 100 of those patients who are receiving IV iron. It is a transient flushing and truncal myalgia reaction, and you need not worry about this. Sometimes we think it is a hypersensitivity reaction or anaphylaxis, and steroids and stopping of iron is some people follow, but we need not do that. We can still observe and hold the iron for some time and restart iron with 50% rate. So Fishbane reactions are quite common in newer iron preparations. So these are various reactions you can get. Anxiety, staph anxiety is there. Sometimes you can get extravasation, you can get flushing, you can get Fishbane reaction, anaphylaxis after 5 to 30 minutes of starting of iron, and flu-like symptoms after 24 to 72 hours, and hypophosphatemia after FCM is quite common post 5 days of iron. So which patients do develop iron reactions? Those who had a history of reaction to intravenous iron, fast infusion, mastocytosis, history of other drug allergies, asthma, eczema. These are the patients who can develop iron reaction to injectable iron. And this is how we manage iron reactions. Mild iron reactions can be managed after stopping the infusion for 15 minutes and restarting iron infusion by reduced rate, that is 50%. While in severe life-threatening hypersensitivity reaction, we should stop it and we should give adrenaline and other supportive care. And if patient is improving, do not re-challenge iron in such cases. Drug provocation test can be tried in some of the patients who had a history of iron reactions, but it is not advisable if some patient, if patient has any history of iron reaction in past, like in the form of anaphylaxis, we should not re-challenge. Even if the molecule is different, if patient has received sucrose in past and he had anaphylaxis, changing over to other molecule is also not advisable. PCV transfusion, what about PCV transfusion? Only if patient is unstable, lethargic, syncope, heart rate is more than 160, RR rate is more than 30. In such situations, we can give PCV transfusion, and hemoglobin is less than 7. But if you have a stable patient with hemoglobin of 5, we can still observe that patient and we can give them injectable iron, and we can see the response. The PCV transfusion should be given at a rate of 5 ml per kg over 3 to 4 hours. Moving to the topic of recurrent iron deficiency anemia, or topic of iron refractory iron deficiency anemia. You will get such cases. A patient who is coming after 2 to 3 years with recurrent anemia, patient coming after 1 year with recurrent iron deficiency anemia. So in such cases, we should think about celiac screw, H. pylori infection, pernicious anemia, and TMP-RSS mutation if there is a familial history of iron deficiency anemia. So I would like to share one case. 15-year-old Muslim boy presented with easy fatigability. He was having this was his CBC. Hemoglobin was 10.6. MCV was 170. Clearly, it is a megaloblastic case of megaloblastic anemia, and RDW was on a higher side. Knuckle pigmentation was there, and his B12 levels were 45. Iron was also on lower side, and ferritin was 2. So, and peripheral smear was clearly showing a picture of megaloblastic anemia with some component of iron deficiency also. So, a Muslim boy who is a non-vegetarian developing B12 deficiency is a rare situation. So, we thought why he's having that. So, despite of having non-vegetarian food, why is developing megaloblastic anemia? So, coming back to our basics of physiology, if you see the absorption side, iron and folic acid absorption is in duodenum and ileum, while B12 is absorbed at terminal ileum. So, we thought we'll go ahead with the scopy and see what is happening over there at stomach level and duodenum level. And his scopy was showing picture of pernicious anemia, and his intrinsic factor antibody was done, which was strongly positive. So that's why he was having B12 as well as iron deficiency anemia. Moving on to next case, 41-year-old male, recurrent anemia. He had iron deficiency anemia. He developed a reaction to ferrous carboxymaltose. Peripheral smear was showing dimorphic picture. Folic acid levels were low. So his scopy was done. Scopy showed D2 biopsy was done, which showed a picture of lymphocytic infiltration in and suggestive of celiac sprue. His IgA TTG was strongly positive, and simple measure of gluten-free diet was given to that guy, and he is now free from anemia. So such cases are quite common, and for such cases we should look at the causes of something is going wrong in that patient, and simply treating iron deficiency is not advisable. If we find out the cause, we can treat it. This was a 54-year-old gentleman, recurrent B12 and iron deficiency. He presented with weight loss and abdominal pain from last 6 months. And his scopy was done. It showed adenocarcinoma in IC junction. So such cases are common in our practice, and we should pay attention to such symptoms, and such cases should not be missed. So take-home message is iron deficiency anemia is not a diagnosis per se. The correct management of iron deficiency anemia is to find and treat the underlying cause, and to give iron to correct anemia and replace the iron stores. Thank you.
Thank you, Dr. Nilesh, for a very good lecture. I think many of the concepts, you cleared them up very well. Any questions?
Nilesh, excellent talk. I had one question. In your practice, when you give IV iron, what is your product that you use the most, isomaltoside or ferrous carboxymaltose? And do you use Avil hydrocot before the injection, and how long do you give? If you are giving 15 minutes, half an hour, just one question.
Okay. So ferrous carboxymaltose, I am using it on regular basis, sir. And isomaltose, yes, some of the cases I do use it. But ferrous carboxymaltose is I'm using commonly. It is
even in pregnancy.
Yes, even in pregnancy, third trimester, I am using it, sir.
How long do you give that infusion?
Yeah, so infusion, I am giving it over a span of 1 to 2 hours. I'm not giving it in 15 minutes. The minimum duration required for giving FCM is 15 minutes, but maximum you can go up to 2 hours. So I'm giving it over 2 hours.
And
no Avil and hydrocot before.
You don't give?
Yes, sir.
What about serum hypophosphatemia? Do you do serum phosphorus levels 1 week, 2 weeks after giving IV iron?
No, I'm not doing it on regular basis. I'm just doing it with for those patients who are coming back after 7 days with some sort of weakness. Yeah.
I think, Dr. Vaishali.
Actually, you said it's a very simple topic, but you made it a lot of things simple here. So very exhaustive and good talk. What is the role of STFR?
Okay. Soluble transferrin receptors, yes, we can, it is a sensitive test which can be utilized for diagnosing iron deficiency anemia, but we have peripheral smear and other parameters which will clinch the diagnosis of iron deficiency anemia. Doing STFR will not add much to the diagnosis, but if you have some cases where the patient has been on iron supplements and he has received some sort of iron supplement in the form of injectable or oral, and still you want to prove it is iron deficiency anemia, then yes, you can advise that. Because after iron supplement, the iron studies and ferritin can come normal. But STFR will be on a higher side till a span of at least 3 to 4 weeks.
Thank you.
Thank you, Dr. Nilesh. Thank you for your wonderful talk. It's very lucid and wonderful. Thank you.
Thank you, sir.
I would like to felicitate our chairpersons, Dr. Vaishali and Dr. Divya. Mansi, can you please? Thank you for your time and thank you for chairing the session. Thank you, Nilesh. Thank you. So we have had some very exciting talks. We have another very interesting talk on refractory anemia by Dr. Siddesh, and I would like to invite our senior chairpersons, Dr. S.V. Kulkarni, sir. He is the senior physician, diabetologist, and I would say a digital expert in technological medicine. He is organized so many national conferences, and it's a proud privilege to have him here on board as a chairperson. I would request Dr. Ajay Kukreja, a good friend of mine, senior physician, also to join as the chair. Next. Yeah, you could introduce the speaker. Thank you.
Thank you. After a relatively easy paper of iron deficiency anemia, we are turning towards a still difficult subject of a recurrent and refractory anemia management. And before the start of presentation, I am inviting all of you tomorrow at MGM Medical College for a very innovative and unusual out-of-the-way conference of Telemedicine Society of India. It is from 9:30 to 4 p.m. It has got 2 MMC points. It has got an exhibition of the things which you otherwise could not have imagined, and the medicine coming in the next 10 years. And now coming to the topic of refractory recurrent anemia, We get so many patients with a big fat file, and they say that there is no change in their iron status. How to approach that? Can I have the next slide? You have to be very careful nowadays when the mic is open or not, considering the current political
Just a second. We are just uploading Dr. Siddesh's introductory slide. He has the presentation. You just need to upload this seat.
Dr. Siddesh is a renowned hematologist from Nashik, a graduate of GMC and MD Medicine from Amritsar, DM in clinical hematology. He is trained in stem cell transplant and bone marrow transplant. Very close to us in ACTREC as well as in Seattle, USA. He is a fellow of American Society of Hematology Subject Achievement Award. Many publications and prizes at his credit. Siddesh, we request you to make a complex topic simpler for all of us. Over to you, Dr. Siddesh.
You can upload your screen. Yeah.
Hello. Hello.
Yeah, we can hear you, Siddesh.
Yes, good afternoon. And are my slides visible?
No, slides are not visible.
Sir, I think you will have
1 minute.
to stop sharing from there.
1 minute. Share, stop.
Yes.
Stop. Yeah, I think now you can upload. We can see you.
Okay. No, it's correct.
Yes. Now we can see your slides.
Yes. In full screen mode, right? And the slides are moving? Hello?
Yes, we can see your slides, Siddesh.
Yes, okay.
You will have you will have to move them from your side.
Okay, yes. So thank you so much, Puneet sir. Thank you for inviting. Thank you, chairpersons, for kind introduction. So this is very common situation for us, and we see simple cases coming to us, and they are inadequately managed. So I'll just present few cases, and before that, I would like to. And nothing replaces good history taking and clinical examination. This is what our teachers have been teaching us, both at ACTREC and ISTM. That benign hematology is more important and more difficult. So coming back to first case, 2-year-old gentleman who has his own transport business, presented with symptomatic anemia. In May 2023, he was on blood pressures, and he was very sincere with his regular follow-ups, doing all his lab investigations on time and at periodic interval. So I had a good opportunity to look at the trend of his hemoglobin. In January, it was 14, in March, it was 12, and in April, it was 11 grams. Apart from this, he had pain in bilateral testicle and lower abdomen, which was being managed by with USG proven epididymitis and inguinal cyst. Occasional alcohol intake once in 7 days or 15 days, non-smoker, family history was non-contributory, and previous prescriptions showed metformin, aspirin, atorvastatin, and predominantly on vegetarian diet. He had mild knuckle hyperpigmentation, so I thought that this could be an easy case of B12 deficiency, mild lower abdominal tenderness, no hepatosplenomegaly and lymphadenopathy. He had previously visited another hematologist in Nashik and was thoroughly evaluated and advised bone marrow examination. After all routine investigations turned out to be normal. And I think this was completely a reasonable proposal. All of us do that after initial baseline investigation. If nothing turns out, we propose bone marrow investigation for this patient. But the reason why he came to me was he did not want bone marrow examination, and that's the reason he came to us. So his CBC was absolutely normal except anemia, which was normocytic, normochromic. Peripheral smear was normal. Retic count is, these all investigations are done previous clinic. I'm just reading those out. RFTs, LDH, LFTs, quantitative immunofixation for multiple myeloma was also done, and that was also normal. Stool occult blood was negative. Iron studies, including ferritin, was normal. B12 was 450, that was also normal. And he had also received trial of B12 and folate before he came to us. And direct cum test was negative. When I proposed him marrow, he told, doctor, look, I'm here because I don't want to do marrow. So if you can diagnose me without doing bone marrow, only then I'm going to stick to you. Otherwise, I'll again go back to my previous hematologist. So then I thought that let us review the history again. Then while I was talking to him, then he informed me that initially he did not have that great anti-diabetic control, but primary physician, but for last 3 months, he had started some Patanjali product, and with that, his sugars are being well maintained. So I asked him to get the photograph of that product, and when I saw that it contents, I found that there was Shuddha Shilajit in it. So, and then I again asked him whether you have been taking any Bhasma, Kada or anything during COVID times. So he informed that 2 years before, he had also taken these Shilajit drops, which were being marketed on the website of Patanjali as good immunity booster for respiratory illnesses and during COVID time. So we ordered his lead level. Arsenic was normal, but lead came back at 83, which was very high, and normal range is 0 to 9. So the next thing was, it is very difficult to get out heavy metals out of body. So he would certainly need chelation therapy. So we tried to search this drug, Saximar in Nasik, but we did not get it. So from India Mart, we found it from Chennai, and then we ordered that. So he was started on 10 mg per kg 3 times a day for 5 days, followed by 10 mg per kg for next 14 days. And this was his CBC after 3 to 4 weeks of treatment. His HB had again improved to 13.8 gram without any transfusion requirement. Then I went back to history. Pain abdomen had also started settling and was not probably related to epididymitis, but was related to lead toxicity. Even if I would have done marrow, I would have done conventional karyotype, fish analysis, NGS for this patient. I think I would have not got anything in this case. So what I learned here was it is very important to give enough time to your patients, take detailed history, and no molecular testing will replace history taking, however advancements we make. So this was my first case. Coming to next case. She is Miss RD, who is 53-year-old female. She was on mixed diet and presented with severe anemia. 2 months before, she had HB of 6 gram, normocytic normochromic picture, and ferritin of 6 nanogram. She also had history of pica. She had received IV iron with primary care physician, and she had marginal improvement up to 8 gram. Beyond this, there was no improvement. On examination, knuckles and tongue were hyperpigmented. There was mild splenomegaly. In our clinic, CBC showed HB of 8.5, platelet 60,000, WBC 3,000, normal differential, MCB was 116, RDW was elevated. 1 day prior, she had received injection elderweight with primary care physician. So this is a very, very common situation wherein we are referred patients, and then before referring, they had already received B12, they had already received ferritin and iron injection or folic acid, and we are supposed to make diagnosis in such scenario. So how do we do or how we go about here? We order first thing is peripheral smear examination, and in that there was marked anisopoikilocytosis, macrocytic RBCs were there, and orthochromatic RBCs were present. That means nuclei was retained in RBCs. And in peripheral smear examination, also hypersegmented neutrophils were seen, which are seen for up to 7 to 14 days, even after the first dose of injection B12. Apart from this, now since this patient was referred and I know that when patients come to us, primary physician who has referred us expects that some kind of diagnosis is given to patient conclusively. So I started gathering the supportive evidences for B12 deficiency. So we did LDH, which was more than 1000, bilirubin was 2.6, and indirect bilirubin was 2.3. Now these investigations, LDH more than 1000, there are only 3 reasons in common practice. First is B12 deficiency. Second is thrombotic microangiopathy, which can be anything. It can be TTP, HUS, or it can be DIC, or it can be acute fatty liver of pregnancy. So any TMA can have LDH more than 1000. And third one is acute leukemia. This was not acute leukemia. Peripheral smear was normal. Patient was absolutely stable. And also coming to bilirubin, if we see here, bilirubin is 2.6 and indirect is 2.3. It is very, very common for severe B12 deficiency to have indirect hyperbilirubinemia in range of 2.5 to 2.6. This is not uncommon situation, and the reason for this is that when the RBC size increases, when they try to come out of bone marrow or from reticuloendothelial system, there is hemolysis which is happening. So B12 deficiency is also one type of hemolytic anemia, except that there is low reticulocyte count in this condition as against in other hemolytic anemia where there is reticulocytosis. So this I have already discussed, LDH more than 1000, B12 or IHA, TTP, leukemia. But IHA cannot have leukopenia, so that was not being explained. So everything favored B12 deficiency. MMA and homocysteine could have been done, but I don't do this. Rather, I give trial of B12 and folate because these investigations are expensive. Elevated indirect bilirubin, I have already discussed. Next thing was treatment of this patient. Please remember, B12 replacement is lifelong in most of the cases if no overtly correctable cause is identified. What I mean to say is that if a vegetarian has developed B12 deficiency and after a few months decides to become a completely non-vegetarian, in that case, I might consider stopping B12 replacement. But for other patients, if vegetarian has become B12 deficient and wants to be vegetarian throughout his life, then this patient will be at risk factor for B12 deficiency throughout his life. Now, if risk factor is going to persist for throughout life, then maintenance has to be there on monthly interval for rest of his life. Otherwise, these patients will come to us again after 3-4 years of B12 replacement. Second common cause for B12 deficiency is pernicious anemia. Also here the absorption circuit is gone. So here also B12 replacement would be lifelong for practical purposes. It is also very important to understand to look for concomitant iron deficiency. Nilesh sir has already described this, that pernicious anemia might have concomitant iron deficiency, and these patients need to be screened for iron deficiency on regular interval. Coming back to DDs of macrocytic anemia, B12 folate deficiency we have already discussed. In practice, methotrexate is one drug which can have macrocytosis, zidovudine, hydroxyurea, aplastic anemia, MDS, hypothyroidism, and autoimmune hemolytic anemia. And I forgot to write here liver disease also. But what distinguishes B12 deficiency or folate deficiency from these is that B12 and folate, if patient has not received transfusion and if deficiency is severe, then MCV is usually more than 113 or 111. So for practical purposes, if MCV is more than 113 or 111 with elevated RDW, it is almost always B12 deficiency. Second common differential cold agglutinin disease, wherein MCV is more than 120, but commonly B12 deficiency is there. Whereas other reasons of B12 deficiency, other reasons of macrocytic anemia will have MCV in range of 96 to 104 or 105. So this is there. But again, this is also not uncommon for B12 deficient patients to have MCV in range of 98 or 104. What I meant to say was that if MCV is very high and RDW is elevated, then it puts in a lot of confidence in us that we are looking at B12 deficiency. So we have already discussed B12 deficiency is common in vegetarian and replacement is usually lifelong. This is how we replace B12. We give daily for 7 days, then once a week for 4 weeks, and once a month. Lifelong for practical purposes until and unless a correctable cause is identified and that has been replaced. I do not prefer oral B12, but for some patients who are not willing to take it, then if at all you feel that there is pernicious anemia or if it's diagnosed, then high dose of B12 in range of 1000 to 1500 can be given, because here the absorption pathway is not used, here osmosis is used at very high doses. Coming to case number 3, this is Mr. Abhay Zadav, who is 32-year-old male. He presented with history of refractory transfusion dependent anemia for 2 years. His basic workup included normal iron, B12 studies, normal HPLC, no family history. Reticulocyte count was less than 0.5%. His bone marrow examination revealed diagnosis of significantly decreased erythroid precursors. Parvovirus PCR was negative. Other autoimmune workup was also negative. He was being treated with cyclosporin 100 milligram BD, which is a standard of care for PRCA, without satisfactory improvement. His weight was around 80 kilogram. He was referred for allogenic transplantation. Now, when we look at donor availability for this patient did not have completely matched sibling. He had already come up with all the investigations, and haploidentical transplant was being contemplated. We asked relatives to hold on that for now and reassess marrow with conventional karyotype. Repeat testing was also consistent with PRCA and normal karyotype. So a cyclosporin trough level was sent, and it was seen that cyclosporin level was below therapeutic level. So first thing we did was cyclosporin levels were optimized, and now when he came for follow-up, patient's HB was stable at 9.5 gram and is improving with cyclosporin and danazol. Probably we will avoid haplotransplant for him because, I was also skeptical to do haplotransplant because that would be replacing one chronic, that might be a situation wherein I would have replaced one chronic illness with another chronic illness. For 2 years, this patient got inadequate immunosuppression and would have been subjected for BMT. Now, moving to next case. This is Mrs. Nagpure, who is 68-year-old female who was diagnosed and treated for iron deficiency anemia. Recurrent time, multiple times she had received oral tablets, iron tablets. Her LDH, bilirubin, reticulocyte count were all normal. Direct cum test was negative. Since she was postmenopausal female. Now, two set of individuals. Always remember, if male develop iron deficiency anemia, or postmenopausal women develop iron deficiency anemia, because they are not having menstrual cycle. So there is no reason for them to develop iron deficiency anemia. So if this group of patient develops iron deficiency anemia, then it is very important to do upper GI endoscopy and colonoscopy to find out from where these patients are losing iron. So that was also normal. Then we did a marrow wherein iron stores were decreased and nothing significant was found. Conventional karyotype was normal. So a PNH flare was sent and this came out to be positive. She was started on IV iron and folic acid supplements. She had inadequate response again, and hence danazol was also added. After a few weeks, this patient presented with frank hemolysis. Now, explanation for this was there was increased hemolysis by facilitating production of large population of PNH RBCs after iron replacement. So initially there was picture of marrow dysfunction, which later on turned out into frank hemolytic anemia. This patient was started on steroids. I did not have access to eculizumab, and that has been stabilized. HB has been stabilized at tapering doses of steroid. What I learned here was that even in absence of frank hemolytic anemia, PNH should be in differential diagnosis, particularly if postmenopausal women or men at any age develops iron deficiency anemia where there is no cause for blood loss identified. An iron replacement can aggravate hemolysis in PNH. This was also a lesson I learned. Now moving to next case. This is young female with refractory cytopenia. She is 20-year-old female presented with bicytopenia, and this bicytopenia was for 3 to 4 years, and she had accustomed her body to low HB that she was absolutely stable. She walked in my OPD when her HB was below 3 gram. She was evaluated multiple times for anemia, treated with multiple courses of iron, B12 and folic acid. Reticulocyte count was 1%, no overt evidence of hemolysis, and direct cum test was negative. Previous marrow done elsewhere was megaloblastic picture. This was her report when she presented in OPD. HB was 2.65, WBC was 1,520, and platelet count was normal. It is very, very difficult for patients who have already undergone marrow or any set of investigation which is expensive to convince them to do that investigation again. But somehow I could convince her, and I asked her to do a repeat bone marrow examination. Here, marrow was cellular, but there was a particulate, so a sort of inconclusive report was reported by very renowned hematopathologist Sehgal sir. So he did a biopsy, and in biopsy we found cellular bone marrow with marked stromal edema and focal grade 1 fibrosis. Just to complete her examination, her workup, I also did a MPN workup which was negative. I was very sure this workup would come negative because at this age we hardly see myeloproliferative neoplasm. Rarely we see that, but at this age commonly we do not see. So fibrosis which was there was also grade 1 fibrosis, and this patient was symptomatic for last 3 to 4 years. So if that would have been the primary fibrosis, I would have not expected to have grade 1 fibrosis. So ANA was sent, and this patient's ANA turned out to be positive. So her diagnosis was autoimmune myelofibrosis. And if we see the criteria for autoimmune myelofibrosis, these patients have mild degree of bone marrow fibrosis, usually grade 1, and have some kind of positivity for any kind of autoimmune antibodies. So this patient was started on steroids, and this is her HB 2.65 presentation, and delta value is 11.56 grams. And now the patient is on tapering doses of steroids along with hydroxychloroquine, and is also being managed by rheumatologist. This is my last case. This is 67-year-old male who had failed repeated B12 and folic acid courses and does not have any evident cause of anemia. When we say that everything has been done just for paucity of time, I'm not displaying all the reports. What I want to show here was MCV is more than 117. So as we discussed previously, MCV more than 113, there are very few causes. So, but when I looked at RDW of this patient, this was 14.4. My machine's range is up to 15.6. So this patient had very high MCV, which was again a surprise for me. Usually B12 deficiency patients have elevated RDW also. So since RDW was normal, which was unlikely for B12 deficiency, despite MCV more than 113, we immediately went for marrow. Other times I wait for doing bone marrow. I'll also give trial of B12 folate for 3 weeks and then only I'll call patient. But here we immediately decided to do bone marrow. And what we found here was MDS with excess blast. And this was also proved on CK. We got recurrent cytogenetic abnormality in form of trisomy 11. So to take home, nothing replaces clinical examination and history taking. It is very important to take detailed history of your patient. And when patients are not improving, then it is of utmost importance that give enough time to patient and try to find out what it is. Also, I wanted to make point about MDS, like when we make diagnosis of MDS in era of molecular diagnostics, there is something called as CHIP, wherein the clonal hematopoiesis of indeterminate potential, wherein we might have some kind of mutations positive, but patient has not gone to a stage of frank MDS. There was similar one case wherein we did entire workup. Biopsy was suggestive of MDS. Genetic workup was also having DNMT3A positivity. But then when we took history of this patient again, we found out that he was taking a lot of Zincovid since COVID times. So basically we ordered copper levels for him and then copper levels were found to be on lower side. So he had CHIP, he did not have MDS. And when zinc was removed from his prescription and when copper replacement was started, patient had dramatic improvement. Just for paucity of time, I am not displaying that case. But thank you, Punit sir, for allowing me, and thank you everyone for patiently listening.
Thank you, Dr. Kalantri. It was a very clear and crisp presentation. That's really a very interesting way of presenting it. So any questions by anyone?
Yeah, I have an interesting question. Actually, Siddesh, first of all, lovely talk. You make us realize that refractory anemia actually it's a huge topic and it is not a very small topic that can be covered in 20-25 minutes. So the range of cases that you showed, actually it's very interesting and important to evaluate from that perspective. So my question to you is, heavy metals, other than lead, which do you think can also cause such refractory anemias? I mean, lead is something that we have seen. What about copper? What about other heavy metals? In your experience, have you seen anything like that?
Arsenic is one which should be thought of. Mercury is one which should be thought of. And occupational history here is very important, like what patient has been exposed to. So that is important.
So in that situation, do you suggest that we should evaluate the heavy metal? There is a screening, right, in Metropolis?
MDS, when we suspect MDS, copper levels and lead levels are must, and I have started doing it routinely because I will miss copper deficiency if because we might have similar picture as of MDS in copper deficiency. There might be hypolobation of neutrophils, there might be dyserythropoiesis. So exactly same picture can be there. And these things, I explain patient that these are correctable things. So please, these are not expensive investigation. It is not waste of money. It is investment in your health. So I explain them and I try to order a heavy metal panel for patients who have MDS.
Thank you. I don't have any more questions. No questions.
Yeah.
Any question from your side? I don't have any.
Yeah, so I just wanted to know if there is any regional variations, like having a borderline high MCV in a different region with everything else normal. Can it be considered normal? Why I'm asking you this is, very commonly we, at least I have spoken to a few other physicians, we have observed in the north, we have seen the MCVs being borderline high, 96 to 105, with a normal to low normal hemoglobin and other normal cell lines. Investigated thoroughly, especially Kashmiris. Kashmiris are very good non-vegetarians. They eat almost every meal as non-veg. Kashmiri Pandits and other Kashmiris also. But this is a very common finding. You hold calls, tikkus. Similarly, a similar finding with something like Bengal platelets or with Bengalis. So is that your opinion about it?
So, like, I'm not aware of the MCVs of North Indian, but in certain belts, MCV can be low because of delta or thal in North India or beta trait. But I'm frankly speaking, I'm not aware of this phenomena. To large platelets, I am aware of that North Indians have large platelet. Rather, entire eastern border of India, from north, from Haryana to down, they have. But for MCV, I'm not aware, sir.
Thank you.
Thank you.
Thank you, Siddesh. Thank you for this lovely talk. We would love to felicitate you from here virtually. So
I would
thank you for your
to come
time.
here, but we are taken transplant.
No worries, no worries, no worries. Thank you. So I would like to felicitate our chairpersons, Dr. S.P. Kulkarni sir and Dr. Ajay Kukreja. Thank you for your time and chairing this wonderful session. Thank you, Ajay. So we are a little short of time and we proceed immediately to the next session on anemia of chronic disease by my dear friend, Dr. Suraj. For that, I would like to invite senior chairpersons, Dr. Sandeep Rai, sir. He is a diabetologist at Apollo and a senior professor of medicine at MGM Medical College. And in addition, I would request Dr. Lakshman Jesani. He is our go-to man for all infectious diseases. Anything, fever, contact this guy. Thank you, Lakshman.
Can we have the CV slide, please? Yeah, very good afternoon, one and all. And it is my pleasure welcoming Dr. Suraj Chirania. He is an adult and pediatric clinical hematologist and a bone marrow transplant physician at the HCG Center in Borivali. And he specializes in various type of hematological disorders like aplastic, sickle cell, ALL, AML, and so on and so forth. He is a very good speaker and he has plenty of publications to his name. So without any much ado, I'll welcome Dr. Suraj to please start with his presentation.
मुझे ईमेल किया था ना ओह मुझे लगा तो लेके आया कोई बात जस्ट अ मिनट हाँ तो ये Just a 2-minute delay. We are uploading the slides. Honestly, yeah, it's sent. I got 2 minutes. It takes time. Okay. 2 minutes लगता है. Quite long. मानसी वाला कर मानसी भेजो ना. आएगा it will take a minute. It's okay. Relax, no worries. It will take time. First. Yes. शेयर करना है PPT.
Dr. Suraj, over to you.
Sorry for the delay. Thank you, Chairperson, for a wonderful introduction, and thank you, Dr. Puneet, for inviting me for this Anemia Masterclass. So, coming to an important topic of anemia of chronic disease. This topic is more one of the most theoretical topics, because the treatment underlying for the treatment of anemia of chronic disease itself is correcting the underlying cause. So we will look into the theoretical background of this important topic. If you see, Dr. Aditi has told us what are the basic classification of anemias. So it comes in the hypoproliferative anemias secondary to the illnesses or inflammation. If you see, it's the second most common after iron deficiency anemia, and in hospital references, this is one of the most common cause we got a referrer for our patients. So what you see in anemia of chronic disease is a hallmark between disturbance in the iron metabolism, underutilization of iron, sometimes macrophage sequestration that leads to the limitation of iron availability to the erythroid progenitor cells, and sometimes iron restricted hematopoiesis. So what are the underlying causes that leads to anemia of chronic disease? Mostly, if you see in our setups, infection is one of the most common cause. It can be any viral, bacterial, parasitic, fungal infection. Sometimes those causing a chronic infections. Then malignancies, hematological as well as solid malignancies, autoimmune causes. Most of our concerns come from the rheumatological colleagues because their patients mostly RA, SLE, most of the patient can have anemia of chronic disease, and they give methotrexate also most oftenly. So anemia of chronic disease is very common in their subset of patients. Then chronic renal failures and chronic heart failure. These are the most common causes of our anemia of chronic disease. Our focus will be understanding the iron metabolism, what's the role of hepcidin, what is the pathophysiology, how we approach and differential diagnosis and treatment. So if you see the distribution of iron inside our body, every adult has a 35 to 45 mg per kg of iron. Hemoglobin has 1800 mg of iron. Myoglobin enzymes 300 mg. Iron storage are in liver and macrophages is 1.6 gram, and total absorption in gut and losses are between 1 to 3 mg. So our daily requirement of iron is not much, is 20 mg only, but the most problem happens when especially in Indian females because of the menses and during the pregnancy and lactation. Yeah. So if you see our dietary iron is after taking that, the absorption happens in the duodenum. Then from duodenum it has transferred to the various compartments for their utilization and storage. Storage mostly happens in the liver and reticuloendothelial cells, and utilization in the bone marrow. And sometimes which are stored in the mucosa and gut, they get discarded and sludge off through the feces. So that is a cause for the loss of iron. So if you see our oral iron that get absorbed on the apical surfaces of the mucosa. So by the ferric reductase, it gets from these ferric, it converted into ferrous, and it gets bound and stored in ferritin in the mucosa surfaces, and with the help of ferropontin, it gets transported to the plasma, where it bounds to the transferrin and goes to the desired location. So iron that is retained in the enterocyte, they may got lost after the mucosa cells sludge off. So what you see, the hepcidin is a very key regulator in iron metabolism, and is a mediator of the anemia of chronic inflammation. So it's a 25 amino peptide, first isolated from human urine. So site of synthesis is liver. From that it got name hepcidin, and it has a bactericidal, antibactericidal properties, and it has a major role in iron metabolism and a regulator of iron transport. So if you see the structure, it's a beta sheet structure with a peptide backbone, and along with the cysteine bridges. So why it is important? Because it is an important link between the host defense and the iron metabolism. It is an acute phase reactant. IL-6 is secreted by the macrophages, and IL-6 increases synthesis of the hepcidin by the liver. So what it does, it inhibits the cellular efflux of iron by degrading the ferropontin. We have seen in the previous slide, ferropontin transport the absorbed iron to the plasma. So this efflux has been stopped because of the hepcidin. So the iron are there in the mucosal surfaces only, and it reduces the quantity of circulating iron by limiting the egress. Means it also prevents the transport from the storage iron like liver and the macrophages. So this is a very crowded slide. So if you see in various part in our body, hepcidin is a major controller. First at the site of absorption, second at a site of storage like liver and macrophages. Then during any inflammation, IL-6 gets secreted and it increases the hepcidin levels. And it in turn increases the IL-1, TNF alpha and interferon gamma. these all has a inhibitory effect on the erythropoiesis then. So it leads to chronic immune activation. So hepcidin, why it is antibacterial? Because it has been, we all have heard like iron is important for the growth of the bacteria and viruses. So hepcidin just take food from those so that their growth is inhibited. So it's get activated in chronic immune activation when there is a altered iron hemostasis, abnormal iron sequestration. It leads to the impaired erythropoiesis and blunted erythropoietin response because of this. And this all leads to the anemia of chronic disease. So if you see fever and reduced iron, this is an interaction as a host defense to the bacterial infection, and this is an adaptive factor for anemia of chronic disease. The fever associated with infection shown to inhibit the bacterial growth and decrease the iron concentration, and that acts synergistically with pyrexia to inhibit the bacterial growth. It called as a nutritional immunity, but there is no evidence like iron supplements can increase the risk of infection when there is a evident infection. So how we'll approach? So sometimes there can be, because the diagnosing anemia of chronic disease is almost after excluding the most common causes of anemia like hemoglobinopathies, nutritional, bleeding, hemolysis. Medication is also one important cause for anemia, and bone marrow infiltrative disorders including the solid as well as liquid malignancies. Exclusion of iron deficiency anemia is important in the setting of ACD. So how it present? It present with a mild to moderate anemia, normocytic, normochromic, reticulocytopenia, and associated markers of inflammation like neutrophilia, monocytosis, thrombocytosis, high ESR and CRP, and there is a decrease in serum iron and transferrin saturation. So there is a normal to decrease transferrin saturation. There is a high ferritin. Soluble transferrin receptor and ferritin ratio is important. So yes, this STFR increases IDA, but it's normal in ACD. So if you see the ratio of STFR by log of ferritin, if less than 1, then ACD is more likely. More than 2, iron depletion with or without anemia of chronic disease. So sometimes this reticulocyte hemoglobin content is informative, like whenever we give iron, the measure of HB is increased. This is the earliest marker of hemoglobin increase. So hepcidin assay is detected by the mass spectrometric methods. There can be immunological methods, and urine and serum sample can be taken to see the hepcidin assay. It is high in the inflammatory and malignancies. However, levels may not be elevated when there is a coexistent IDA, as inflammation induced increase in hepcidin production will be opposed by the effects of the iron deficiency. So distinguishing patient with pure ACD from those with combined ACD and IDA. So hepcidin level we usually don't use as a routine, but if you want to distinguish between two, this will be a very important test. So if any patient of anemia is there, means hemoglobin less than 13 in male and less than 12 in females, then we see the markers of inflammation are present. Transferrin saturation is less than 16%. Then exclude other causes of anemia. If along with transferrin saturation less than 16, ferritin reduced and MCH is less than 27, it's a iron deficiency anemia. If ferritin is normal and the ratio of STFR and log to ferritin is raised along with the hepcidin normal, then it's a combination. While the ratio is less, then it's anemia of chronic disease. So classic distinguishing features between the IDA and SAD, as we've seen, IDA, the classic features are low MCV, then low MCH, low MCSC, high RDW, and in iron studies, the TIBC is high and ferritin is low. In opposed to anemia of chronic disease, these are reversed, MCV, MCSC, most of times they are a little low or normal side. Transfusion saturation, TIBC is decreased in anemia of chronic disease compared to iron deficiency anemia, and ferritin usually is increased in anemia of chronic disease. So these are the most distinguishing features between the IDA and anemia of chronic disease. So then next, like growth differentiation factor 15, it is also a erythropoiesis derived hormone, markedly increase in thalassemia and chronic dyserythropoietic anemia. It inhibits the hepcidin expression and contributing to the iron overload seen in these anemias. So subjects with both ACD and combination show significantly higher levels of GDF-15 than patient with solely iron deficiency anemia. So this also can be distinguishing features between the both of them. So when we see the other confounding factors like thalassemia, sideroblastic anemia, so mostly in thalassemia, microcytic hypochromic pictures are there. Serum iron in thalassemia and sideroblastic anemia are normal to high, while it is less in anemia of chronic disease. Ferritin levels are almost low to normal in anemia of chronic disease, while it is pretty high in both thalassemia and sideroblastic anemia. And hemoglobin pattern is normal in anemia of chronic disease and sideroblastic anemia, while it is abnormal in thalassemia. So coming to next part, the management of ACD. So the anemia of chronic disease, usually it's mild. Then why to treat? Because sometimes these are the patients where the other organ and are affected, mostly cardiovascular system, where they require hemoglobin to maintain the oxygen supply. Anemia may be associated with poor prognosis in many chronic disease states, and treatment may improve the quality of life in such patients. So if you see, we need to correct the underlying pathophysiology for correction of anemia of chronic disease. So correction of the underlying factor like infection, malignancy, rheumatic causes, that we need to do. Then hepcidin suppression will be helpful. When there is combination, then iron therapy will improve. Blood transfusion is a temporary measure that will increase the requirement, and most importantly the erythropoietin, because most of them decrease the erythropoietin levels in anemia of chronic disease, that aggravates the problem. So coming to individually treatment of underlying disease, sometimes definitive treatment like immunosuppression, steroids in autoimmune problems, TNF alpha inhibitors, sometimes in HIV related treatment, because HIV is also one of the most common cause of the anemia in infective causes. So initiation of HALT can improve the hemoglobin, and nutritional support. So blood transfusion usually we do when there are emergency, when any cardiac patient having hemoglobin less than 7, only for severe life-threatening anemias, because it has his own hazards. So the most important thing what we use is erythropoietin stimulating agents. So erythropoietin is secreted by kidneys as a glycoprotein. So it stimulates the differentiation of the committed erythroid precursors and inhibits the apoptosis of the erythroid progenitor. What we see, there is a blunting of response of erythropoietin in anemia of chronic disease. And comparatively, there are low serum levels of erythropoietin that we usually do while evaluating the anemia of chronic disease. So by giving these erythropoietin stimulating agents, we can treat the anemia of chronic disease. So if you see, most of the things, majority of results are in CKD patients, where dose is administered twice to thrice weekly to weekly doses. So 150 units per kg subcut thrice weekly or 40,000 units subcut weekly for 4 weeks sometimes shows a very good response in 2 to 3 weeks. Epoetin alpha therapy also for long acting and darbepoetin agents are also available. So mostly the patients who received ESRD patient received these erythropoietin stimulating agents have a lower mortality. So there is a multi-center study of RCA in correction of anemia in rheumatoid arthritis. So dose-dependent response to 50 to 150 units per kg of EPO 3 times a week. So most of the patients showed a good response. So epoetin alpha therapy for hematological malignancies and mild anemia, if we see, it increases the hemoglobin, functional capacity, well-being, work and productivity while these patients are under treatment because of the chemotherapy, and they are in a good remission state. So relationship of ESA and responsiveness and adverse outcome in CKD, starting dose usually 20,000 per week subcut. If hemoglobin response is seen, the dose can be decreased and the duration prolonged to titrate the hemoglobin to a asymptomatic level. Response usually can take 4 to 8 weeks in CKD patients, and it's seen in good amount of patients in 40 to 80% of cases. So if you see this flow on the right side of the screen, if any erythropoietin levels are less than 100 and change in hemoglobin in more than 5, so if you see the patients having a good response to the EPO, if erythropoietin levels are more than 100, so we always think that giving erythropoietin supplements may not be useful for them. And even if these erythropoietin levels are less than 100 and hemoglobin change is less than 0.4, so sometimes the positive predictability of not having response is 80%. So ferritin levels and the erythropoietin levels are very good, needs to be done before giving the erythropoietin stimulating agents. So these are various erythropoietin stimulating agents. Long actings are available: epoetin alpha, beta, darbepoetin alpha. Darbepoetin alpha is very commonly available in India, while rest are mostly used in UK, US. So is EPO safe? That is the next question. So sometimes there can be a risk of cardiovascular incidences, thrombosis and tumor recurrence. So if you see in correction of hemoglobin outcomes in renal insufficiency, anemia correction to 13.5 by 1 weekly in CKD patient would decrease the mortality and cardiovascular morbidity. So, but that was the primary hypothesis. But when they done the trial, so they found that when the hemoglobin increased more than 13.5, the chances of death because of the cardiac events are high. So that trial was deferred. So if you see the trial in this, so because of the increase in diastolic BP, venous and arterial thromboembolic events, the causes of death were high in darbepoetin arm, so this study was terminated. So this was same happen in the one non-small cell lung cancer related anemia. So these are the so that's why after this termination of studies, the recommendation of FDA on use of EPO was use the lowest dose of ESA, which gradually increase the hemoglobin concentration that will avoid the blood transfusion. Treatment of ESA might increase the risk of cardiovascular events, so should not be administered when hemoglobin is more than 12. So an ESA should not be used in specific tumor types like breast, head and neck, and small cell carcinoma of lung. So or the patient having an active malignancy, not receiving any chemo and radiation therapy. So depending on that, this was designed. So the EPO uses were designed. So iron therapy, when there is a functional iron deficiency.
Sir, kindly summarize.
Yeah. So we are concluding the session. So anemia in ACD contributes hugely to the morbidity experienced by millions of patients suffering from a large variety of inflammatory, infective, and malignant conditions. Treatment of the primary cause is possible, and that is the most important. And EPO with iron supplementation in appropriate cases, and specific treatments are under study, so that hepcidin antagonist, these are in study, so the future can be bright on the treatment for the ACD. Thank you.
Thank you, sir, for a very informative presentation. Sorry for interrupting you because lack of time.
You. Yes.
And how do you decide to escalate the dosing?
So usually, because the normal recombinant erythropoietin we need to give 2 to 3 times per week to avoid the discomfort and the visit to the clinics. So I usually use darbepoetin alpha. So usually I start with a low dose, 40 micrograms subcut once in 15 days to 21 days. And check response after the 2 doses usually. If there is a hemoglobin increase in 0.1 to 1 gram, then I stick to the dose targeting level of 12. So, and if there is no response, we gradually escalate to 100 microgram every 21 days. Yes.
500 micrograms specifically
For yes, 100 and 500 is for yes, MDS.
We start with 40, escalate 2 weekly,
Yeah.
or 3 weekly to 100 or 200.
Yes. Yes. Thank you.
Yeah, that was a little specialist question, but for physicians like us, I wanted to know 1 or 2 things. How useful is this STFR test? Is it done? And if it is done to differentiate anemia of chronic disease from iron deficiency, is it useful? Do you regularly do these inflammatory markers also to do that?
Sir, a very interesting question. Only thing when we will do test, when we need to supplement the iron. So if my take is, if ferritin levels are more than 500, I never do this test, because the patient won't the giving iron supplement won't be helpful for serum ferritin more than 500. If the ferritin levels are less than 500, so I do the serum ferritin, this STFR test, to see whether the ratio is less than 1. If the ratio is less than 1, then sometimes we can give the iron supplement along with the erythropoietin agents. Mostly I do this in CKD patients, because CKD is the state of patients, mostly we are using such agents.
No, sir, in CKD we are using erythropoietin. I wanted also to know that in other cases, how frequently you are using, because anemia of chronic disease is common. At what level of hemoglobin you will consider to use, because it has these side effects as you told.
Yes.
So at what level?
So usually I choose to treat when hemoglobin drops less than 9, because most of these people has a lot of comorbidities, so more than 9 hemoglobin is desirable level for them. Yes.
Any questions from the audience?
Thank you.
Thank you, sir. Thank you.
Thank you, Suraj. Wonderful talk. I request Mansi to felicitate our speaker, Dr. Suraj. Dr. Suraj, thank you. Thank you, Suraj. Thank you for your time. Appreciate. I now request Mansi to felicitate our chairpersons. Thanks a lot, sir. Thank you, Lakshman. Really appreciate you coming over here and spending your time. Thank you for this wonderful sessions that we have been having. We now move on to a very interesting session. It's on pre-surgical management of anemia by senior hematologist Dr. Bhave. For that, I would like to invite Dr. Vandana Gaudi Madam, Dr. Nitish Jhawa, Dr. Bindu onto the stage. Are they here? No. Well, I would request our speaker friend, Dr. Suraj, to come. And I think the chairpersons are on the way. Dr. Bhavika. Stop share. Dr. Bhave is here. Dr. Vandana Gaudi is not here. Dr. Bharat, can you please come onto the stage for the chair?
Puneet, can you hear me?
Yes, we can hear you, Dr. Bhave.
Thanks, thank you.
Thank you. Talk. Your talk you will be uploading from your side, right, sir?
Yes.
Yes. I would request our chairpersons to take over.
Hello, good afternoon, Bhave sir. So, Dr. Abhay Bhave doesn't require any introduction. He is a very eminent hematologist practicing in Mumbai. He is our teacher per se. So, he has very illustrious career as a hematologist. So, currently he is working at Lilavati Hospital and his own clinic, and he has presented many national and international papers, and he is one of the leading person who organizes CMEs for all our hematologists. So over to you, Bhave sir.
Thank you, sir. Thank you for the kind introduction.
I'm so sorry to interrupt. I just wanted to invite Vandana Gaudi Madam, a senior gynecologist, on board as a chair. We wanted some surgeons on the stage, so thank you. Huh? Yeah.
I hope my screen is visible.
Yes, it's visible, sir.
Okay. So thank you very much. Anemia is a common peri and pre-operative referral to us hematologists. And if you look at the surgical units that face anemia, I think they are broadly, everyone's included in it. It might be gastrointestinal, mainly colonic events, gynec events, cardiologic, especially cardiothoracic, vascular surgeons, urology surgeons, orthopedic surgeons. You will note over here that the places from where the hemoglobin can drop, obvious sites such as the colon, gynec events, and vascular surgeries, they tend to have a slightly higher incidence of preoperative anemia in the range of 40 to 45%. But what is disappointing is that patients who are going for cardiothoracic surgery or urology surgery, or for that matter orthopedic surgery, where we don't expect them to be anemic before because their events don't actually involve loss of blood. But still the incidence is almost 25 to 30%. This indicates to us that in general, our community has a higher incidence of anemia, whichever branch of surgery or gynecology that they may belong to. And that's a little bit disappointing. In terms of low hemoglobin, there's no doubt that red cell transfusion can be life-saving. But when a multivariate retrospective analysis of 11,000 odd patients who underwent surgery was analyzed, where they were given 1 unit of blood versus no unit of blood, the chances of having complications in the lung, kidney, or hospitalization, length of stay, LOS, or onset of sepsis was more in those who were transfused, just 1 unit of blood. In another retrospective study, when more than 1.5 million patients undergoing various kinds of surgery, were analyzed and looked at whether they received 1 unit or no unit, again, you'll notice that the incidence of perioperative stroke, myocardial infarct, was much more in the range of 2.33. That means 2.5 times more than those who were not given blood transfusion. And this odds ratio actually started increasing when the patient received more transfusions. For the last quarter of a century, when this paper was published in 1997, it was clear that with each transfusion of Paxil, the chance of going into multi-organ failure is higher. And therefore, giving transfusions indiscriminately is not the way to go. So avoiding transfusion or keeping transfusion to the least is the way we have to go. So today's topic of discussion is pre-surgical management of anemia. The two questions posed to me are when and how much. I am Abhay Bhave, I am a hematologist, and I thank Dr. Puneet Jain and his team from the Apollo Hospital and Apollo Cancer Centers in Navi, Mumbai for arranging this Anemia Masterclass. I also remember the 2019 one when I had come there physically. I'm sorry I can't come there today physically. And it's very wise of him to bring out these practical issues and try to find pragmatic solutions on this day for a very common problem in the community. May I just let you know that more than a third of people who have major surgery are anemic before their surgery. And the blood loss of surgery or the trauma can actually worsen or cause the anemia in such patients. I can straight away answer one question. How much is the hemoglobin that is needed for surgery? And the answer is the straight 13 grams, irrespective whether it's a male or a female. So that's the kind of hemoglobin we need. But this is medicine. It's not mathematics. We are going to face situations where we may not be able to achieve 13 hemoglobin. And sometimes in the post-operative phase, the target of hemoglobin need not be 13. And I'm going to even argue for that. It might be as much as 7. So our targets of hemoglobin will change depending upon what phase of the surgical event the patient is in. Preoperatively, we would love to have a higher hemoglobin closer to 13. And post-operatively, we don't mind it dropping up to 7 before we actually think of giving transfusion. And we'll go into those details as we go along. Anemia may not be a confirmed cause of adverse outcome, but it is possible that the underlying anemia may be a marker for some underlying comorbidity that impairs the outcome. So it's very essential to diagnose anemia because something else may be hidden that may impair the surgical outcome were it not corrected at that time. Like I said, there will always be special groups. So yes, we all want a hemoglobin of 13 and my surgical colleague will be delighted to have a hemoglobin of 13. But patients with malignancies generally have a lesser hemoglobin. They are anemic by virtue of their disease and treatment. Thalassaemic individuals, including minor, don't have hemoglobins of 13. Patients of anemia of chronic disease who are now surviving, and therefore we are seeing more and more of them in practice because of excellent supportive care and diagnostic facilities and talent in our country, their hemoglobins are not going to reach 13. And those who have got bone marrow failure syndromes such as aplastic anemias and myelodysplastic syndromes and such like diseases, they are unlikely going to have hemoglobins of 13 at the time of surgery. So when we are looking at a target hemoglobin at the time of surgery, I want us to pay special attention to who's the patient in front of us and what's the kind of a hemoglobin we are able to build up for that patient. Now, I don't want to be a hardliner. I'll say that I'll allow surgery if it's a minor one and the expected blood loss is minimal. The cytopenias may not be significant and the risk of thrombosis is low. I will say yes. And if the surgery is urgent, in fact life-saving, then irrespective what the findings are, I'm going to correct the abnormalities with relevant treatment options. They might be components of blood, there might be blood products, there might be other pharmacological support. And with the help of good monitoring during the surgery and post-operatively, I will say yes to the surgery because life is more important than the risk of taking transfusion. I'm able to do today risk stratification for my surgical colleagues where we can say that, look, if the risk is low or very low, then it is unnecessary to say no to a surgery which might improve the patient's quality of life. If it's a moderate risk, we can look at what is the kind of risk or bleeding that can take place and then decide. Obviously, if it's a high risk of significant bleeding, we are going to be careful and then we are going to be able to assess this patient far more. Remember, anemia is an independent risk that could be associated with poor outcome in both cardiac and non-cardiac surgery. Neither the surgeon nor the anesthetist or the physician hematologist should give unreal expectations of the surgical outcome, as there will always be an element of the unexpected in such cases. A discussion and a daily assessment record should be maintained or documented on paper, and especially if the transfusion is needed, the need of transfusion should be documented, because if there were to be an adverse event, there might be a look back and then we'll have to justify why blood was given. Let me now introduce you to the three pillars of this topic. The first pillar is in the preoperative stage, who is the physician or the hematologist to which the patient has been referred. And I'm hoping this referent doesn't come at 10 o'clock at night for surgery at 8 o'clock in the morning. That's a common thing which happens nowadays. The patient get admitted the previous late night and suddenly the hemoglobin or the platelets or some coagulation disorder is picked up and we get a reference at night. Now you're calling a very tired physician or hematologist to come and assess, and therefore the assessment may not be accurate at that point of time. And to cancel the surgery next day morning might be a major issue. The second pillar is the anesthetist and surgeon, especially in the intraoperative phase. They're very important in order to see that there's no excess bleeding and that they have the proper surgical skills. And the third pillar in the post-operative stage is the intensivist, under whose care the patient is going to go if ICU is needed, or the continuation of that physician, hematologist and surgeon in the wards, if the patient is in the ward. While these three pillars I heard, it indicates to us that any surgical event has to be a multi-specialty management, and therefore you cannot bypass one of these pillars. You need all three, or the event might just collapse. So the most important pillar is the preoperative phase, where a lot of time is spent on finding out genuinely how much is the hemoglobin, is there a need to correct it, what can be the reasons for the low hemoglobin, and whether it can be immediately corrected by non-transfusional methods in order to bring up the hemoglobin so that the patient can go for surgery. Sometimes this may not be immediately possible, and therefore we need to actually take time to build up the hemoglobin and then go in for surgery. If we do bring up the hemoglobin and we say yes, I have seen in my practice, in my experience, that sometimes the intraoperative and then in the ICU, the transfusion of blood may be indiscriminate. For the smallest or slightest of fall, blood is given. So the good work that the preoperative physician hematologist has done may get diluted in the intraoperative or postoperative phase, especially if there's no appropriate indication for transfusion. So let's know our elective surgical patient. We should know more about the patient. So what's the degree of anemia? From a CBC and the indices, along with a good peripheral smear blood examination, we should be able to tell what is the kind of anemia this patient has. We should do the blood group, because sometimes the groups might be rare and therefore we may not have enough blood for the surgical event the next day. Deference. We should have the right of veto. As physicians or hematologists who are seeing the patient for a surgical event following day or the day after that, we should be able to refuse on valid grounds, such as if the etiology is unknown, patient is found to be unfit for anesthesia, the reports have still not arrived, or the patient is on some form of anticoagulation or antiplatelets, or is actually a patient suffering from a bleeding disorder. Then we need time to sort out how to withdraw the drug, give it enough time to reverse, and then go for surgery. I'm talking of elective patients. In terms of etiology, we can do, along with the CBC, iron study, because 60 to 70% of the time, the cause of anemia is going to be iron deficiency. The other 10 or 12% is going to be vitamin B12 deficiency and 5 acid deficiency. Our country also has significant number of thalassemics, so hemoglobin electrophoresis will help us. A smear examination might pick out other odd things, including G6PD related problems, schistocytes, that is microangiopathy, or sickle cells. A bilirubin will tell you whether there is ongoing hemolysis causing jaundice. If there is bleeding history, we must be able to sort that out first prior to the surgical event because that bleeding might just get worse post-operative. Then we must talk to each other, find out what is the nature of surgery. Is the surgery going to involve vasculature? Is there going to be a higher risk of bleeding? What is the anticipated blood loss? Now, there is a term called a major surgical blood order schedule, MSBOS, which helps the surgeon, the blood transfusion center, and the physician to decide whether we have enough blood and blood components available for a surgical event tomorrow or the day after, in case something goes wrong and there's a complication. It shouldn't happen that we are caught without availability of blood at the surgical site, which might be detrimental to the patient's health. At the same time, while concentrating on anemia, don't miss out on the coagulation. The basic coagulation includes, along with the CBC, PT, PTT, and plasma fibrinogen. This will tell us whether there's any ongoing coagulopathy, especially for patients who've got an underlying liver disease who are candidates for surgery. Platelet mapping will tell me whether clopidogrel or aspirin or any of the ADP inhibitors are still on board, because that could indicate to us that the consent prior to the surgery, which should include the risk of blood exposure and the patient's right to veto. In this, I think the art of history taking, communication, and discussion is vital, and it is challenged because we should be able to communicate with all of all our colleagues, all the pillars, and be able to explain to the patient in case there is a risk of hemoglobin dropping, there is anemia which needs to be built, or there is a need to defer surgery. Here, I think we are very important in the community to prevent anemia in a patient by appropriately selecting the patient and then preventing transfusion in such patients. May I introduce to you a 48-year-old gentleman who's planned for hernia surgery with a hemoglobin of 7.5. The treating team has told him that he needs transfusion preoperatively or on table, and so that can be fine for surgery. Since he's applied for leave, insurance papers have been submitted, and most importantly, his wife has also taken leave. He's now been advised to take 2 units of blood and operate. What would you do? So I would obviously defer surgery to try and determine the etiology. Would if his hemoglobin was 6.8, would it make a difference? Would you actually go ahead and give blood? My answer is still no. If he's so stable as to be electively taken up for surgery, the 6.8 needs to be analyzed, hemoglobin has to be brought up, and we would defer surgery. Here is the importance of the first pillar, which says, look, you are not fit for surgery. We should not have a physician who agrees to the surgery at this point of time, especially transfusion. And importantly, there should be concordance of the second pillar, because the second pillar, who is the surgeon, would be very anxious that if I say no, the patient is going to get admitted somewhere else and be on some other surgeon's table and give transfusion and get on. Let that be on someone else's head, not your head. You have to do what is scientifically correct. Please remember, anemia should be viewed as a serious and treatable medical condition rather than simply an abnormal laboratory value, which can, by quick fix hematology, corrected by blood transfusion. That's inappropriate. So we have guidelines for this anemia in the perioperative pathway. We can identify the anemia, make the patient aware of all the actions we are taking, find the cause of anemia, treat it with with tested methodology, make sure that the patient has a personalized investigation and treatment, communicate with the different members of the team, both on the surgical side and on the patient side, and talk openly to the patient that, look, it's in your interest that we need to sort out your hemoglobin better. What questions come up in this case? Questions is, why bother about anemia? Does anemia have an impact on the outcome? Does anemia have an effect on wound healing and surgical outcome? Why not just give blood and perform the surgery? What's wrong? Today's blood is tested. You've got nucleic acid tested blood, as safe as possible. Chance of getting HIV, hepatitis B, hepatitis C is less. Why not just give blood and get on with it? These questions dog us. Well, anemia in surgery has a worse result, slow mobilization, increased risk of death, and the rate of complications is 2 to 3 times more in transfused patients. Anemia as an independent risk factor is responsible for around 20% more complications in these patients. And if you were to give them blood transfusion, the risks, especially which affect the immunity, is even much higher. And don't forget, it's not only the infection, it is the immunological changes that take place which are important. It is the reactions which take place that is important. It is the transference of so many other proteins and viruses going through the blood that we are not testing for, which is an issue. And does this preoperative anemia have an impact on the outcome? For the last more than 10 years and beyond, we know that those who have been transfused have a poorer outcome in terms of morbidity and mortality. It's very clear in the evidence summary that anemic patients are at an increased risk of transfusion, mortality, and major morbidity in proportion to the severity of anemia. So the recommendation would be to ensure anemia screening and correction before the surgery. And patients should be counseled about the relationship between anemia, morbidity, mortality, and should be opportunity to defer non-urgent surgery until the anemia is investigated and treated. This is a grade 1C recommendation. The British Committee for Standards in Hematology guidelines are clear. If the hemoglobin is less than 5, transfusion is essential. Otherwise, we may be able to prevent transfusions and find the etiology and treat it. And remember one thing, a hemoglobin of 6 or a PCV of 18 is adequate for wound healing. So it does not affect the oxygen delivery to the surgical site, and we should avoid whole blood. Remember, when you transfuse blood, you're increasing the hematocrit, and that's why the viscosity of the blood increases, and this may reduce the blood flow in the microcirculation, especially of the surgical sites or of the organs. We must remember our anesthetist colleagues are there to take care of blood loss up to 30% with crystalloids or colloids, and therefore transfusion may be avoided in such patients. Increasing the arterial oxygen content by increasing hemoglobin does not increase the tissue oxygen delivery uptake. So one of the thoughts that the hemoglobin goes up, then the oxygen delivery will be better. Randomized studies have supported the restrictive use of red cells over liberal statins. And I'm going to tell you about this in the post-operative state. And in a meta-analysis of 7,000 odd patients, keeping the hemoglobin at 7 post-transfusion and not giving blood up to 7 for non-cardiac patients, or 7.5 as it is mentioned today by the ABC CRIT and the TRIC studies from different parts of the world. For cardiac patients, we need 7.5. Previously it was 8, now it can be as much as 7.5, unless there is poor ejection fraction, but then those patients would not have been taken up for an elective surgery any which way. And the reason is because when you go liberal transfusion, the risk of healthcare associated infections are much higher in these patients. We would encourage our colleagues to use packed cells rather than whole blood. The days of whole blood are over, and we prefer to give filtered blood rather than use the BG or the blood giving set to our patient. For my anesthetic colleagues and surgeons who are there in this audience, in the intraoperative phase, a meticulous surgical technique, prophylactic antifibrinolytic, topical hemostatic agents, use of a cell salvage wherever is possible, maintaining a good temperature, not letting it be too hypothermic or hyperthermic, and preventing hypotension are very important events because all of these can lead to a DIC and therefore bleeding and therefore need of transfusions and poor outcome. And if transfusions are going to be given, ideally they should discuss with the patient, the family prior to the surgical event. May I also give some transfusion targets to my colleagues? Keep the hemoglobin above 8, maintain the platelet count above 75, keep the PTT less than 1.5 times control, and keep the fibrinogen above 1. If you do this, the risk of bleeding is less, the need of transfusion will be less, and therefore the risk of going to DIC will be less. So the concept of something called a SPAM clinic is very important. It's called the Surgical Pre-Assessment Anesthetic and Medical Clinic, where patients are seen prior to the surgical event, especially if they are anemic. And the outcomes have been far better when such a clinic has been visited to by the patient. Let me come to the last aspect of my discussion. What if I told you that the hemoglobin is fine, but I'm anticipating anemia in a surgical patient? So on one hand, the patient was anemic and we try to find out why, and we try to correct it. What if the hemoglobin is fine, but now we are looking at a surgery where I'm anticipating anemia? Can I do something in this situation? What if I told you that we can avoid allogenic transfusion? That we can give the patient's own blood back to the patient. This is the concept of autologous transfusions. Unfortunately, not very popular for reasons unknown, but if we plan it well in advance, we can do it. So this is a situation where we can use when we are anticipating anemia or anticipating that there will be a transfusion, why not take the patient's own blood and give it back? May I indulge you in a couple of cases? This is a 28-year-old male who came to me, persistent headache, and he was found to have a hemangioblastoma. He needs surgery for that. Incidentally, his hemoglobin was 20, which is why I got involved. Hemangioblastoma is known to give rise to polycythemia as part of a paraneoplastic syndrome. Now, how did we manage this patient? So we did his therapeutic phlebotomy, and we were able to collect autologous blood for him. He underwent surgery after embolization, but still his hemoglobin did drop. He developed post-operative anemia, and in this situation, we gave him his own blood back to him. And I thought that was something which we could do because all the stakeholders spoke to each other and were able to prevent allogenic transfusion exposure. And here it's important for the blood transfusion center to be part of the decision making because they keep the records and keep the blood for us to be used on table. Another patient had come to me who was 58 years with chest pain. He had a triple vessel disease needing bypass after doing a coronary angiogram. Incidentally, on a 2D echo, a mass was seen in the left atrium. A sample was sent across to the blood transfusion center for 4 units of Paxil. That's what the surgeon wanted. And the ICT was strongly positive. ICT is indirect antiglobulin test. It came strongly positive. A detailed testing was done in this, and he did not have any cross-match compatible blood. And we tried to get his family members to see whether the family members would have a similar blood group. Obviously, he had something odd in his blood against which he had formed an antibody. And we found no compatible blood donor, including in his family. No one had this kind of ICT. We could not get compatible blood, but his hemoglobin was 14.3. So how did this manage this patient who needed surgery? We did a whole body PET scan because we were worried about that mass in the LA. We found multiple small lymph nodes in the chest, abdomen, and also in the lesion in the LA. We did a biopsy of one of the lymph nodes. It turned out to be granulomatous disease, but non-tubercular. We put him onto steroids with the aim of trying to reduce the ICT so that we can get compatible blood for him. We've also planned him for autologous blood donation because we wanted 4 units. The surgeon wants 4 units. We do something called as piggybacking in autologous transfusion. That means we will take 3 units of blood at 1 weekly interval, 1 by 1, 1 unit per week. In the 3rd week, we'll give back the first one and take another one. And in the 5th week, we'll again give back the 2nd unit and take another unit. So we'll have 3 units of fresh blood available for us, and then we can go ahead with the surgical event in this patient. So when we are anticipating anemia, we can try to take blood and minimize that risk of transfusion, which we are all worried about. I would love you all to read these 3 articles, which are very recent articles of the year 22-23, which look at recommendations from various societies for the management or trying to give us a consensus for anemia management in surgical patients. I'm going to conclude by saying surgical anemia can have immense repercussions on the outcome. Address anemia with a proper evaluation pre-operatively, try to correct it so that the risk of giving transfusion is least. When we should try to avoid transfusion as much as possible, but if it's needed, I'm not going to be very rigid because life is more important. I will give judicious transfusion to this patient, and I would prefer to use packed red cells. Where it's possible to defer, let's defer surgery, and if a span clinic is available, it will be beneficial. The pre-operative work should be corroborated by the intraoperative and post-operative care that the patient receives by the respective pillars. My last point, how much? We need a hemoglobin of 13, but sometimes we don't get it. So then we have to be pragmatic and we have to be able to manage in those cases. Then in that situation, document the need of transfusion and take consent, preferably pre-operative, and communicate the intraoperative events to the next team, that is the 3rd pillar who's going to manage in the ICU, and the family for what all events have taken place in the theater. Thank you very much. Have a safe, hopefully bloodless surgery.
Wonderful, lovely talk, and the whole idea of your talk was this, the importance of having a good hemoglobin before any major surgery, at least a major surgery. But the reality is many times patients come from far, and it's not always possible, at least in an Indian setup, to have the best hemoglobin. So even in a perioperative situation, what is your assessment of giving IV iron in an iron deficiency just one day before the surgery? Do you think that will make a difference? In an iron deficiency, HB10 and a major surgery planned, do you think that will help?
Well, whether it's given one day before or whether it's given a day after the surgical event, for those who have got iron deficiency, certainly that iron infusion is good. But I want to tell the audience that it takes a while for the hemoglobin to rise after IV iron. It will take somewhere between at least 7 to 10 days for the hemoglobin to rise. So for patients who are very borderline iron deficient anemias, giving IV iron is a very good option. And there's immense amount of data on perioperative IV iron therapy. But where the hemoglobins are low, we need to build it up. IV iron should be given at least 2 weeks prior to the surgical event. If the hemoglobin has been good, let's say the hemoglobin was 14, it dropped down to 10, giving IV iron post-op, excellent idea. It helps to prevent transfusions, it stabilizes the hemoglobin, and it picks up the hemoglobin at the time of discharge, a week or 10 days down the line, so that you don't have to transfuse this patient. So I think it's a good idea, provided the clinical situation is right.
Thank you. Any questions, madam? What is, any questions from your side?
I think that is a very clear message that, build the iron and try to avoid transfusions.
Yeah.
Many a times for the sake of safety of anesthesia, blood transfusion is given pre-operatively just because we are scared that anesthetists are going to reject the case.
Yes.
And we all know that that is not probably the best practice. And these talks and awareness like this sends a very clear message that transfusion should be avoided as much as possible.
That's right.
That's a nice thing.
Dr. Jhawar.
Yeah, so many a times, we see patients who are coming with a hemoglobin of 10 or 11 or something like that. We really don't see the way we should be seeing those patients. Like, if the cutoff is 13, then I think 50% of the patients are having a hemoglobin less than that. And no issue is raised by any of the team members, including the anesthetist, and we rarely call you for these cases. What should we do in such cases? What is the ideal thing to do?
No, so I think that is the point I'm trying to focus, that the least we can do many times for whatever situations unknown, we are not able to postpone. So the idea is peri-operative management, including IV iron or B12, whatever the reason is, or an attempt to find out why. What is the reason for anemia? Surgery may still be done even with HbO 10, 11. But at least if we can give IV iron, if there is an iron deficiency, give B12 at the time when there is deficiency, it goes a long way, because in a week or so, hemoglobin will start to improve. The retic count improves. After 2-3 weeks, the hemoglobin, if iron deficient, will start to improve. So I think that is the clue. The perioperative management in an Indian setup is what we can focus on. Ideally, we should postpone, but patients come from far. So I think we can focus on perioperative IV iron and B12 is the message, I think, which is an important message.
So are you suggesting that we should not operate unless the hemoglobin is 13?
No. So Dr. Bhave, sir, would you like to comment on that?
Yeah, so if you go by guidelines, they want a hemoglobin of 13, and I agree with Puneet that it is impractical for our country where 60 to 70% of our patients have got some form of anemia. Most common iron deficiency. But while I'm a proponent for iron therapy, both oral or IV, we have to be careful that IV iron may not be appropriate for everybody. There might be situations of chronic anemia, chronic disease, which might need erythropoietin. There might be B12 deficiency. There might be marrow issues. So a proper evaluation, and if there is iron deficiency, certainly iron therapy. But if you can't build up the hemoglobin to 13, which is going to happen in more than 50% of the cases, then our aim should be how to prevent transfusion post-operatively. So there might be many surgeons who might say that, look, 10, 11 hemoglobin is more than enough for my surgical event. I don't need 13, so I'm not in favor of postponing this surgery. And we say, fine, let's talk to each other. If your surgical blood loss is not going to be much, and you feel that the need of transfusion may not be needed in this situation, why would I say no to the surgery? I'll say, yes, go ahead with the surgery. If the hemoglobin is 12, you are expecting a drop in hemoglobin, we can do autologous collection for these patients. So I'm not saying no to a hemoglobin of 11, 12, or for that matter 10, based upon what is the kind of surgery. But any surgery where you feel that there's going to be a drop post-operatively, then that discussion has to be documented. That look, you are unable to reach 13, surgery is needed tomorrow. There is a chance that your hemoglobin may drop. There's a chance that you might be exposed to blood. Are you okay with that? So that kind of discussion and documentation has to take place. Because tomorrow, by bad luck, if someone develops HIV, hepatitis B or hepatitis C after the transfusion and there's a look back, then they'll say, look, doctor, you gave me blood. I'm the patient. You should have told me blood should not have been given to me. So they'll turn back against you and say that, why did you give me blood at that time? So that documentation or explanation has to be written down. You may have spent half an hour outside the theater with the patient and relatives. But if it's not written, it's of no use. So you have to document it and say that this is the reason why I give. And therefore, you are justifying the need of transfusion. So I'm not against transfusion. I'm for judicious transfusion. Where a hemoglobin of 6.8 for a hernia surgery would have been delayed, brought up the hemoglobin, then operated, I'm in favor of that kind of a situation. Not to take them up where it can be delayed till you find the exact cause. And you know, these patients coming from out of town and all that are the same persons who will keep hassling you later on. Because you are doing it out of good faith, but they may not react in good faith later on. So it's very important that you document even if they're out of town. If it's elective, they can always go and come back. It's left to us how to impress upon them what is the deleterious effects of transfusion. So it is our ability to counsel, our ability to impress them that will make them understand. If despite that they don't, then that's where consenting takes place. Take the consent and tell them that this is the possibility.
Dr. Bindu, question.
Yeah, thank you, Dr. Bave, for that wonderful and enlightening talk. I'm an obstetrician and gynecologist by profession. So we have a lot of hemoglobinopathies, also patients with thalassemia trait and all those.
Sorry, I've lost. I lost your voice.
So I'm an obstetrician and gynecologist by profession. So we have women with hemoglobinopathies also, like thalassemia trait and all those. So in those women, before any like planned cesarean or any procedure or any gynecological surgeries, what would be the ideal, because we see the drop of the initial hemoglobin, they usually have around 9.5 or 9, then it comes, they may be having parallel some other deficiencies also. So how do you address those women?
So I think that's an important question and a very relevant day-to-day question we see every day. Usually if it's a thalassemia minor patient, the hemoglobin is somewhere between 9 and 11 in our country. We know that there is a concept of gestational anemia. The hemoglobin tends to go low in every woman who gets pregnant by about 1.5 grams. So if you got a lady whose hemoglobin was 9.5 to begin with, it's going to drop to around 8 or lesser than that as pregnancy proceeds, especially in the second trimester and towards the early third trimester, when the amount of plasma volume increases relative to the red cell mass. And that's why you get the gestational anemia. Now, if the fetal growth is good, if the patient is not distressed, there are no signs of failure. In thalassemia trait, we let the hemoglobin drop to as low as 7 or 7.5. We are not going to be aggressive because the starting hemoglobin is 9. So my thinking is that a 2 gram drop from the baseline when she was not pregnant to now would be acceptable to her. In the interim, if there is a developing iron deficiency, vitamin B12 deficiency, I might want to use intravenous iron at this point of time because that's better than oral iron, or sublingual vitamin B12, which I have found works very well. But if it's not there, then that hemoglobin of 7, 7.5 is going to give a lot of anxiety to the obstetrician. Let me tell you that at the time of delivery, more often than not, if the blood loss is not much, especially if it's a cesarean section where the entire hemostasis is in your hands, the risk of bleeding is very less. And therefore, these patients may not even need transfusions. The fear comes in the mind of, pardon my saying this, but fear comes more in the mind of the anesthetist who is giving the anesthesia, especially if it's a general anesthesia. For that matter, even epidural anesthesia. So they get very anxious that the hemoglobin is too low. Even the obstetricians start getting anxious that the hemoglobin is too low. In such a situation, one of the side effects of transfusion is that we also then transfuse the baby. The same blood can go to the baby. And therefore, we want to filter the blood that is going to be given. We want to ideally irradiate, which is not going to happen. And ideally, it should be CMV negative, which is not going to happen in our country. We are 95, 96% CMV positive. So we can't follow the West. So in that case, nucleic acid tested blood with a third generation filter can be given to the patient during the pregnancy in order to bring up the hemoglobin, especially if it's going below 7, 7.5, or the patient is in stress. And at the time of delivery, again, we can give transfusion if needed. In between, in thalassemia, we can also use erythropoietin. The erythropoietin should be that one which does not have benzyl alcohol in it, otherwise it gives rise to lazy baby syndrome. Erythropoietin does not cross the placental barrier, and therefore I have got several young girls of thalassemia minor and thalassemia major who are transplanted and have now sired children. I've used erythropoietin in them to bring up the hemoglobin, or at least maintain the hemoglobin at a level which is compatible with non-transfusion thought process. So 8, 8.5 would be a good hemoglobin where the risk of transfusion will be lesser. And then it's left to us, hematologists and physicians, to implore upon the surgeon, the gynecologist, obstetrician, and the anesthetist that we can get away without transfusion or keep transfusion if there is bleeding on tape. I hope I've answered your question.
Wonderful. Wonderfully well.
Thank you very much, sir.
So I think we are running late, and thank you to Bhavesh sir. I mean, it was a wonderful lucid presentation and a lot of clearance of concepts that we probably would have loved to probably let it be, and there is a lot of clarity in thoughts. Thank you. So I think
Puneet, I think I'll thank you for selecting this topic, because it's not very often that this topic is brought up in our domain. So I'm really thankful to you for thinking of this topic and bring it up. And I can only visualize the Hindi picture, surgeon coming out of the theater in his scrubs, taking out that green cap of his, wiping his sweat on the forehead and saying, "Operation कामयाब हुआ, हमने 2 बॉटल खून चढ़ाया है, patient ठीक है, patient ठीक नहीं है." That's why my worry is those transfusions may be unnecessary. So I hope those days are gone, and I think I'm hoping this discussion can increase awareness. Thank you everyone for listening to me. Thank you.
Thank you. Thank you. Thanks a lot, sir. Thanks a lot. Bye-bye. So I would like to end this session. I would request Mansi to please share a memento to all our chairpersons. Thank you, sir. Thank you, sir.
Okay, I'll take your leave if you don't mind.
Bye-bye. Thank you.
Thank you, everybody.
Thank you. I think we are nearing the end of the session. Dr. Bindu, Madam, Suraj. Photo, madam. I know it's a long day. Thank you. Thank you, chairpersons. Thank you, Suraj. I think we have had a long day. I would request my last speaker, Dr. Vipin Khandelwal, to come onto the stage. I would request our chairpersons, Dr. Ashok Gowdy, sir, senior pediatrician, and Dr. Sawant, again a senior pediatrician, to please come onto the dais and chair the session.
Something. So I know, thank you. Hello, can you hear me? So it's a long session now. I know everyone is sleeping now. So I'll just finish fast because most of the things have been already cleared by our first speaker. And during her session about hemolytic anemia, she discussed about hemoglobinopathies also. So I'll be discussing about hemoglobinopathies and why it is important, like because anemia, we know it's a commonest public health problem in our country, and iron deficiency anemia is the commonest cause. Besides iron deficiency anemia, the second commonest cause in our country is hemoglobinopathies. And just let's see the structure of our hemoglobin. So it's a very complicated structure, and mainly it includes 2 alpha chains, 2 beta chains, and heme moiety. So what are hemoglobinopathies? They are basically genetically determined disorders of hemoglobin, and in these disorders there can be a qualitative defect or can be a quantitative defect. Qualitative defect, if you can see in this second portion, like in sickle cell disease, which we see similarly, like quantitative disorders in thalassemia. So you will be surprised to know that India is known as thalassemia capital of the world. Why? Because 40 to 50 million individuals are having thalassemia in our country. And every year, more than 10,000 children are still taking birth and who are having transfusion-dependent thalassemia, and they are indication for allogenic transplant. So this is a major distribution of thalassemia all over the world. Beside this, hemoglobin E sickle is also having worldwide distribution in our country also. So let's discuss about some cases, and these are some common scenarios which we see in our practice. And my case first is a 7-month-old child, male, born of non-consanguineous parents from West Bengal, and there is failure to thrive. Clinical examination is showing splenomegaly. So whenever in our country we see a child who is having like 6 to 7 months of age, having severe anemia, requiring transfusion with splenomegaly, we think of thalassemia major, which we now called as transfusion-dependent thalassemia. So this was the smear which was showing nucleated red blood cell, microcytic hypochromic picture. There was severe anemia. Other blood parameters were normal. So how to confirm? Yes, definitely we have to go for hemoglobin electrophoresis, and this revealed that the hemoglobin fetal was high in this case. The other electrophoresis is showing the normal picture, in which the fetal hemoglobin curve is there initially, then the A, which is the peak curve, followed by the A2 curve. So this child was having beta thalassemia major, and both the parents, if we do HPLC, will find that they are minor thalassemia, and I will show in my further slides how the pattern of hemoglobin, what is the pattern of HPLC in beta thalassemia minor also. So this is very important to know the thalassemia status of the parents, because if both parents are minor, then there is a 25% chance of that the child will be having a beta thalassemia major and who will require lifelong transfusion. So genetic counseling plays a very important role in hemoglobinopathies, and the standard of care in this scenario is either lifelong transfusion, keep hemoglobin more than 9, and once we are giving frequent transfusion, iron level will increase in their body, so they will definitely need some iron chelators. there are so many iron chelators are available in our country, and if you want a permanent cure, yes, definitely allogenic transplant is the only hope for these children. So if you are not transfusing them well, then they will have such type of faces, they will have big spleen which will cause abdominal distension. So it's always better to prevent this disorder and know about hemoglobinopathies. So this child is now an 11-year-old girl having anemia. She was having mild anemia, and most of the time the picture we see for anemia is a microcytic hypochromic, and the iron parameters in this child was previously were like low, so the child was given a trial of iron, but even after giving trial of iron, the hemoglobin didn't improve to the normalized. So the HPLC was done, and which was showing the peak in the hemoglobin A2 level. So if the hemoglobin A2 in HPLC more than 3.5%, then it's thalassemia trait, beta thalassemia trait, or thalassemia minor. So this is also one scenario in our country, like those who are on iron, but they are not responding, their anemia is not responding because they are beta thalassemia minor, and in beta thalassemia minor, definitely their hemoglobin will be little bit lower. This child, 16-year-old girl with chronic anemia, and she presented in emergency with acute chest discomfort. Her saturations were very low, and her peripheral smear was showing sickle cells. Her complete blood count was low, severe anemia was there, no organomegaly was there. So such type of presentation can be seen in our country, especially like for sickle cell disease, they can have sometimes recurrent pain crisis, sometimes acute chest syndrome, sometimes they can present with stroke, or sometimes priapism. So the HPLC pattern will show the peak in the sickle curve. This is the HPLC pattern which we see in case of sickle cell disease. So how to manage such type of cases? Like whenever they are coming with crisis, we have to properly hydrate them, we have to oxygenate them, and yes, if they are anemic, give transfusion. So giving top-up transfusion will dilute the hemoglobin sickle level. And yes, if you want a cure, then the only allogenic transplant is the only cure. But yes, there's one medicine, hydroxyurea. Those who have recurrent crisis, hydroxyurea, it creates wonder, and most of them now then will not require a transplant also. So this child is a 6-month-old child with anemia, and there's no history of consanguinity, thriving well. And examination, yes, pallor was there, spleen was there. So again, the same presentation. So hemoglobinopathies, they have presentation in early childhood only. And sometimes it's not always the case simple, like it's a beta thalassemia sickle. Sometimes we can see the combination of different hemoglobinopathies in the single patient. So this child was the similar, that case, and the anemia, 6-month-old child, splenomegaly, they can have high LDH. That all are the parameters of hemolytic anemia. So the complete blood count was showing that the hemoglobin was low, 8.7, but the total RBC count was normal in this case, and platelets and other parameters were normal. So whenever you are seeing a complete blood count and the anemia is like MCV is low, but the RBC count is normal, think of hemoglobinopathy. So in this child, further HPLC revealed that the hemoglobin fetal was high and sickle percentage was also high. So it was a mixture of sickle and beta thalassemia. So by doing mutation analysis, we'll have idea and we'll have confirmation that what type of mutation is in their family. And yes, if we do the HPLC of the parents, we'll have the clear idea about what is the hemoglobinopathy in our child. So this child is having the similar combination of hemoglobinopathy. This child was having E thalassemia plus beta thalassemia. So he was diagnosed to have E beta thalassemia. And the child was having the similar presentation of anemia, splenomegaly at the age of 1 year, jaundice, indirect hyperbilirubinemia, and the HPLC pattern was showing the pattern of E beta thalassemia. So in our country, we see not a direct case of beta thalassemia, sickle, not a direct case of E disease. We see is a combination of sickle beta, E beta, so many patterns are there. So this child is a 1-year-old male, failure to thrive, and splenomegaly was there, and the complete blood count showed anemia, peripheral smear was showing picture of thalassemia. So at the age of 1 year, so the child is requiring now transfusion, so we'll label it as a intermediate type like picture. Usually the major picture will be, they will require transfusion in infancy. So around 6 to 7 months of age, they will requiring transfusion in major, but intermediate, they will requiring transfusion beyond the infancy. So this child was showing picture of thalassemia, but now if you are seeing such type of picture, you will think, yes, that both the parents will be minor thalassemia, yes? So the HPLC must be deranged. But in this child, father was normal. Father hemoglobin was normal, and the HPLC pattern was also normal in the father. And mother was thalassemia minor. So how it is possible? Like the HPLC is normal in father, the hemoglobin is normal, and but mother is having thalassemia minor and the child is having picture like of a major. How it is possible? It is possible when sometimes we have silent mutations. So it's a complicated picture. So father, even the hemoglobin was normal, the HPLC was normal, but he was carrying a mutation which we call silent mutation. So this can be the situation sometimes. So silent carriers are those, especially they are from Punjab, and these are some common mutations which we see those who have silent thalassemia carrier. So this is a 17-year-old female child with history of pallor for last 10 days. They are from Jharkhand. So sometimes the picture is not only the hemoglobinopathy. In India, they can have both hemoglobinopathy, iron deficiency anemia. In addition to that, they can have some other disorders also. So just this is a case of having multiple causes of anemia. Hemoglobinopathy was also one cause in anemia in this child. So 17-year-old from Jharkhand, thriving well. Clinical examination was normal. Spleen was there. So the complete blood count showed low hemoglobin, severe anemia was there, but WBC was little bit high. It was neutrophilic leukocytosis. Peripheral smear was showing anisocytosis, poikilocytosis, microcytic hypochromic picture. So previously then this child was treated for iron deficiency because the iron parameters were low. So like 40 to 50% of population is having iron deficiency anemia. So the child was correctly given the correct treatment, but even after giving iron, the child was not responding. The hemoglobin patterns was not improving. For the parameters, whenever we see anemia not responding, the microcytic hypochromic anemia, which is not responding to iron, will do HPLC. And it was showing the hemoglobin D trait. Just I am sharing this slide. Why? Because the hemoglobin D trait, hemoglobin E trait, or even the hemoglobin E disease, hemoglobin D disease, they do not cause severe anemia. They will have only the mild anemia, or sometimes they can be normal only. But this child was having severe anemia with hemoglobin D disease, so think of some other causes also. So later on, it was found that this child was having DCT positivity also. So it was an autoimmune hemolytic anemia, and leukocytosis was also there. Initially, I was thinking maybe this was a reactive leukocytosis, but on the smear there were basophils. This child turned out to be a chronic myeloid leukemia also. So there were so many reasons for anemia in this child. Hemoglobinopathy was one reason, but iron deficiency anemia, autoimmune hemolytic anemia, CML, so many reasons. So these are some complicated pictures which we can see in our country. So when to suspect hemoglobinopathy? On seeing the blood count. So whenever we are doing a complete blood count, see what is the hemoglobin. Yes, that will tell us whether there is anemia or not. Then look for the RBC count, look for the MCV, and look for from where they are. Like India, we know we can have so many cases of hemoglobinopathy, but those who are from African descent, the sickle cell disease is the common disease. So seeing MCV, RBC count, we'll have idea, yeah, if MCV is low, RBC count is normal or high, it is thalassemia minor. But in iron deficiency anemia, what will happen? MCV is low and RBC count will be also low. So whenever such type of picture is there, do electrophoresis. Electrophoresis will tell us, yes, which type of hemoglobinopathy is this. But even now, there's one situation like MCV is low, RBC count is normal. So we are thinking it's hemoglobinopathy, but HPLC is also normal. So then what it could be? Alpha thalassemia can be there. So we have to do the genetic testing that will confirm, yes, this child is having some alpha thalassemia carrier or the state. So what all parameters which I have already explained, any child with microcytic hypochromic anemia with normal RBC count, think of thalassemia. So these Manzer index is a derived parameter which is MCV upon RBC count. If in case of thalassemia minor, it is less than 13, the values are, and in case of iron deficiency anemia, the values are more than 13. So the main thing is like look for CBC, look for RBC count, look for MCV. So MCV low, RBC count normal, think of thalassemia. So yes, history is always a very important point which one should take to identify whether it's which type of anemia the child is having. Sometimes in family history we'll have history of jaundice, history of gallstone, history of transfusion dependency, and clinical examination comes also, and in thalassemia they will have the typical phases. Sometimes if we have spleen, we have liver, think of some hemolytic anemia. Leg ulcers are common in case of like sickle cell disease. RBC indices and peripheral smear and HPLC will confirm the diagnosis. So this is the normal pattern of HPLC. Initial curve is for fetal hemoglobin, then is for hemoglobin A, which is the normal hemoglobin. Hemoglobin A2 comes later on. These are the normal patterns of hemoglobin in adult, like it's more than 95% hemoglobin A. Hemoglobin fetal is less than 1%, A2 is less than 3.5. In the newborn period, yes, it's the different picture. Hemoglobin fetal is the predominant hemoglobin. So there are other causes of elevated fetal hemoglobin, like hereditary persistent of fetal hemoglobin in delta beta thalassemia, inherited marrow failure syndrome. And one should know the normal levels in the infancy. Like at birth, the hemoglobin fetals is 90%. At the age of 6 months, it's less than 8%. At the age of 1 year, it comes to the normal adult value. So why to know hemoglobinopathy, especially in pregnant females? Because if the pregnant female is normal, then no need to do screening in the partner. But yes, if the pregnant female is the thalassemia carrier, then we have to check for the partner also whether he's suffering from thalassemia carrier or not, because these all things can only prevent the birth of a child with the beta thalassemia major. So thank you, and any comments from chairperson and any questions?
Like your first slide only said that the incidence in India of thalassemia is too high. How do we strive to make India thalassemia free? There is a country, you must have heard about Cyprus, which was almost every. Now today they don't have any cases of thalassemia.
Correct.
So what would you tell the government to do, and how do we get it? It is possible.
Actually, yes. So for Cyprus, the population was very less. In India, we have like 150 crores. So proper screening programs, yes, definitely we have to focus on that. It is difficult, I know. It's very difficult.
See, like today we have an Aadhaar card, I think so everybody on this.
No, you can throw light on this, because I know it's very difficult task for a government to just screen 150 crore of population. So
but 150, they have been screened for Aadhaar cards, I suppose they. So I think so. See, I don't say think it's difficult on this earth with our technology and how fast we are moving as a country. I think so. We should have that, and it should not be difficult. I don't say that two thalassemic traits should not marry. But if they marry, they should be screened.
Yes.
So we can decrease the incidence. I think so. It is possible. I don't think it's not impossible. It's not impossible. Every time we just hide behind this facade. No, it is not possible. We are such a big country. But we have shown the world our Aadhaar system is more robust even than the American social security systems.
Hopefully, let's see. No, but yes, sir, you are right. Like if it is possible in other country, why not in our country? Yes.
So my first question, Dr. Vipin, how sensitive and specific are these indices, Menzer index, Shine and Lal index, and Englander-Fraser index, in differentiating between thaltrate and iron deficiency anemia? And my second question is, if either of the parent is either thaltrate, when we should do a HB electrophoresis in a newborn child?
Okay, so like first question, you are asking about the derived parameters, all what we get from the complete blood count. So definitely the complete blood count, if we see the MCV and the RBC count, more than 90% they will be able to tell us, yes, whether the child is having iron deficiency anemia or whether the beta thalassemia trait is there. So we can just highlight them. Yes, if the RBC, which I've already explained, RBC count, if it is normal and MCV is low, definitely there is high probability that this child could be the thalassemia trait. Yes, but sometimes silent carriers, I've told in my one case, silent carriers can be there even when everything is normal. So most of the time we'll be able to identify by the complete blood count and the derived parameters that whether the patient is having thalassemia minor or not. But yes, the exact sensitivity and specificity that I have to search for. But yes, most of the time we'll be able to identify, definitely.
But sometimes
because what we are seeing, like by the complete blood count and what our hematopathologist is also seeing by the smear and the complete blood count, and they are saying rule out thalassemia trait. So almost 100 times, the HPLC will reveal that yes, definitely it's a thalassemia trait.
But sometimes MCV may be slightly higher, or it may be normal in vitamin B12 deficiencies and folic acid deficiencies. So in that situation, what should we do?
Yeah, sometimes, but they will have the mixed picture, microcytic and macrocytic. Both types of cells will be there. So we have to see smear.
Regarding my second question.
Okay, so second question, can you repeat again?
If either of the parent is either
so when to screen the newborn? Okay, so yes, the newborn, if you want to do a genetic test, on the day one also it will reveal, yes, whether the child is having thalassemia major or not. The genetic test will confirm everything. And what I will say, HPLC also if you are doing in the newborn period, and if you are finding hemoglobin A0, that also shows, yes, maybe the child is having thalassemia major. Because the hemoglobin A, it starts appearing in our, after 28 weeks of gestation. So if you are finding hemoglobin A0 in the day one of the newborn, you will think it's the child is having thalassemia major maybe. But yes, the ideal time is after the age of 6 months.
When? Would you offer every sickle child with a transplant, or would you screen, or what are the points that you would consider?
Okay, so as per the limited literature which we have about sickle cell disease in India, the severity of sickle cell disease in India, it is lesser than what is in Africa, which you also know. So as per the data, but yes, most of our patients, they are still undiagnosed and they die. So we do not have the exact amount of what is the severity of our sickle cell disease patient. And yes, when to transplant them, there is the criteria are clear, like those sickle cell disease patients, like who are not responding to hydroxyurea. Even on hydroxyurea, they have frequent crisis. That is definitely an indication of going for transplant. And if they have one episode of stroke, that is also an absolute indication. So
one major event is what you would consider. Otherwise, would you consider a child who is stable on hydroxyurea,
as per guidelines, we should not consider, and I also don't consider. Yes.
Yeah, agree. That's what I wanted to.
Yes.
Thank you. Any more questions?
How often you do the investigations in a patient who's on hydroxyurea? because it is known to cause complications and
Yes,
side effects.
definitely. So what we do is every 3 monthly we do CBC, and we look for the sometimes they can the creatinine and bilirubin will also rise. So every 3 monthly we should do CBC, liver function, and or you can just do OTPT, bilirubin, creatinine. So every 3 monthly. Those who are on hydroxyurea, because hydroxyurea is also known to cause cytopenia. So definitely they need monitoring. And by doing CBC, like you will have idea also about the compliance. If the MCV is high, that means the child is taking hydroxyurea.
With regards to hydroxyurea, how do you actually administer? It's available as a capsule, 500 milligrams. How do you administer hydroxyurea in children?
So, like, pediatricians can definitely answer this question. So, some medicines are always available in the capsule form. So, we remove the capsule, take the powder, dilute it.
Children learn to live with it then they learn how to live with it.
I know, but I was just trying to, actually, this is a very, this is a topic for discussion every time in our hematology meeting.
No, correct.
Hydroxyurea in children, how do we actually...
No, sickle cell disease, like it's quite common in Maharashtra.
because we use it
Still, we do not have the syrup form, but yes, it is not available, so what we can do?
We use that even in certain thalassemia intermediate, correct?
Yeah.
So, that point of discussion. Thank you, wonderful discussion. Any more questions? So I would, before ending the session, I would really like to thank the audience for staying with us. You know, kudos to you. I know it's a post-lunch session, and thank you for staying with us. So I would request Mansi to give a memento for our chairpersons, Gowdy sir and Dr. Sawant. Thank you. Mansi, can you share? Yeah. With Dr. Sawant. Kindly felicitate our speaker, Dr. Vipin. I now request everyone to please come onto the stage. We would want to have a group photo. Please stay on the stage. We are having a group photograph. Everybody from the audience, please join us. Thank you, everybody.